All right. Exactly. Yeah. Sure. Sure. What we can do is just
Just a coffee mug and a pen.
nice. Nice.
Official, but I mean,
Oh yeah, it's good. It's good. And it's so big.
folks, if they email me a question, I'll just wait for you.
Good morning, everyone. Can you hear me okay? Awesome. So thanks everyone for coming today, in person and virtually. I think we're about like half and half, a truly hybrid event. So I'm David Chong, and I'm the one of the geriatric psychiatrists here at the University of Saskatchewan, and the current CME director. And so, yeah, welcome to the 2024 Psychiatry Academic Day, which we have a very interesting topic to discuss. And we are a more intimate crowd here, so hopefully we can also generate a lot of interesting discussion and questions throughout the day. So I'd like to start off with our land acknowledgement, and to say, as we gather here today, that we respectfully acknowledge that we are on the land of Treaty 6 territory, traditional territory and homeland of the Métis, and we want to pay our respects to the First Nations and Métis ancestors of this place and reaffirm our relationship with another. So here's a rough agenda for the day, and we'll get started very quickly here, but just a few housekeeping notes before we go on to the first talk. First of all, I just want to remind you that this is a CME accredited event, so please also complete the online survey that will be sent out later this afternoon. And it is, this is a Section 1 CME accredited event. And also that there is a email that you can send in questions to that Dallas, our communications officer, will be checking throughout the day, and then that will be brought to the discussion panel later in the afternoon to also discuss. And yeah, please do the survey. So first, to get started, I'd like to introduce our first speaker, who many of you are familiar with. It's Dr. Lillian Thorpe. She's a professor in psychiatry and also in community health and epidemiology at the University of Saskatchewan. And she's actively involved in MAID-related clinical work, teaching, research, and also development, and has contributed to policy and guideline development since 2015. And she has served in the Saskatchewan Health Region Committee, developed the regional MAID policy as well, and is a member of the Saskatchewan Health Authority Ethics Committee as well. And she has been part of the CAMAP teams for capacity assessment and guideline development, and also is a member of the Canadian MAID Practice Standards Task Group. And she completed her education here at also University of Regina and also University of Toronto, and fellowship in Vancouver as well. So I'd like you to welcome Dr. Thorpe, please.
Thanks very much, David. Thanks, everybody. It's nice to see people. I get so busy, I never get out to things often see everybody here. So it's wonderful to see everybody. And this is a pretty difficult topic for many of us. We all worry about our patients. We worry about how we're going to manage things that might change with the law here. So it's a great topic to have us talk through. And we've got a variety of people who will help us with approaching how we're going to do this. Mona Gupta is going to talk later. She's very involved in national processes and knows how some of the other folks have been looking at it. And some of us have been going to national meetings, getting ideas from others as well. So we'll all get a chance to do a bit of talking about this, and especially with lots of feedback in the afternoon. So there'll be an open panel where we'll all speak a bit. So I'm going to just make sure we have this. So is this showing up? Okay, yes, it is. Okay, I have to just mention, I'm going to turn this around a bit so I can see this. So I do have some disclosures, which is that I had some money from CAMAP for doing some of the teaching modules for across the country teaching MAID, and that money came from Health Canada. And so those are my disclosures. And then you heard my biography, and my other disclosure is that, my God, I've been involved with MAID assessments. I haven't quite updated how many I've done, but as of last week, I had done 1185 assessments since 2016, when the law changed, and there was initially a regionalized approach to MAID, and so some of us in Saskatoon Health Region developed policies and so on, which now we have a provincial program. But since that time, I've been very, very busy. So it seems to be busier all the time with people asking for medical assistance in dying. So I just put that up as a disclosure, because obviously I'm obviously a supporter of medical assistance in dying. I wasn't always. I was initially quite concerned prior to MAID and meeting so many people who are suffering that I did change, and I'm obviously in support of developing processes that will let people have a peaceful end to suffering under practices that are going to make our patients safe. So for those of you, so I don't know if we can upload and pass our PowerPoints to everybody, but I did put a bunch of references in there that you can click through there, click and find more there. So I don't know, David, if there's a way we can send out the PowerPoint to whoever's interested, because I'm happy to have people, oh good, he's going to do it. So I'm happy to have the actual PowerPoint go out, not just a PDF of it, because people can use it and make it better. So this will be in there. So you heard learning objectives. So what I'm going to do is talk a bit. I'm actually going to start with a continuum of approaches to end-of-life decisions. And I think that's really important to remember, that MAID is only one part of many aspects of end-of-life decisions. Many things come before that. And then we're going to do a brief review of what the law has done to allow MAID to start with, and then how it changed in 2021 to allow for Track 2, which is people without reasonably foreseeable natural death, and that is why MAID for sole mental illness becomes theoretically legal. And now, of course, that's been deferred again, but Track 2 is what underlies that possibility. And so then I'm going to talk a bit about the balance of autonomy and protection for vulnerable patients. Many of you know I'm very involved with vulnerable patients on the ethics committee. I've been very concerned about many processes in many areas of medicine for vulnerable patients and how we make some of those decisions. So death is not easy for many of us to talk about. Woody Allen said, "I'm not afraid of death, but hey, I don't want to be there when it happens." So we're not comfortable. We often don't talk about death. We all die. Every one of us will die. And we often don't talk enough about this. And in our patients, we want to make sure our patients talk about goals of care before it even gets to some of the other aspects like MAID. We got a ways to go. So living can be worse than dying. So a lot of our patients have told us that. So this is here Sue Rodriguez, who had ALS. She was dying a difficult death. She initially said, if I cannot give consent to my own death, whose body is this? Who owns my life? She wanted the right to end her life on her terms, to decide how, when, and who she controlled how she would die. She applied. At that point, the Supreme Court didn't approve these changes in the law, but her advocacy ended up resulting in lots of discussion across the country, and was eventually resulted in MAID legislation. So here's a guy who has more recently talked about living can be worse than dying. So he has gone open about this. He says, he talks about access to MAID for people with primary mental disorders. And through Dying with Dignity, he has filed an application saying it's discriminatory to bar people with mental disorders from being eligible for an assisted death when it's available for people who are suffering physically. They're both suffering. And so what he says, he was a war correspondent, and his name is Scully, last name is Scully. He was a war correspondent with significant PTSD. He's had a lot of treatments from all kinds of modalities. He has ongoing horrible nightmares, terrible PTSD. He's 83 years old. He can't sleep. He lives in constant fear that he will end his life by suicide. And he knows that this is really difficult for the survivors. There must be a better option. So life is worse. Living can be worse than dying, not for just physical, but also for mental health reasons. We all know there are a few patients, no matter what we do for them, they don't get better. And I'm going to show you a case of one I had long before MAID that we ended up looking at comfort care. So what is a good death? We all have the right to good death. The World Health Organization says that a good death is free from avoidable distress and suffering for patients, family, and caregivers. This is not the case when a person ends up their life in suicide, in a basement, in isolation, with great distress resulting to that person and then to the family and the coroners who've told us how awful this is when they find them, families who will never forget this. So the way we die should be consistent with clinical, cultural, ethical standards. This is way back. Unfortunately, over the past century, we became very medicalized in how we saw dying. More people died in hospital, which gradually has come down as we've talked more about dying. And I think some of this has to do with the focus on medical assistance and dying, where we're more open about saying, what do we want when we die? We're all going to die. So you see rates of deaths in hospital coming down over time. Now, unfortunately, we still do many things for people at the end of life that are not helping them. So this is for people with medical issues, but we all know some people with psychiatric disorders that are very refractory, for whom we also do all kinds of things, have on multiple interventions that are not helping in spite of what we do. So this is not a good thing for people, and it's good keeping in mind that what we do is not always for the benefit of patients. It's sometimes for our benefit because we feel that we need to do something. So we have general principles that I think in geriatric medicine and psychiatry we talk about, which is when things are not working, let's deprescribe, let's take away some of these treatments that are no longer helping, let's focus on functional improvement, let's look at what's actually helping in terms of time needed for benefits, so how long does this take, and then maybe active interventions that we might want to talk about stopping. And then before we talk about palliation and medical assistance in dying. So this is an example of a woman I recently saw. I can't remember what house staff was with me, but how we don't always do this well yet. And this is a 95-year-old woman I did a MAID assessment for at St. Paul's Hospital. She was on more than 20 different drugs. She and her family, or actually it was her family on her behalf, asked for medical assistance in dying. She was a bit impaired with the medication she was on. She was very short of breath. She was on some Dilaudid, but she very clearly said she wanted to die a peaceful death. and very consistent, but couldn't give me a lot of details. I'd have had to drop her Dilaudid considerably to get her clear enough to be approved for MAID. And so there were palliative beds available, and it was clear she would die quite quickly. She was really sick with many, many things wrong with her, as well as the pneumonia at the end. And so then we end up seeing, so she had comorbid illness. So she also had a long history of depression, and questions often arise in these cases with comorbid illness. So these are issues that are very similar to the ones we're going to be dealing with MAID for sole mental illness, and we're already dealing with those issues. So this is a woman where we have to think, does she have decisional capacity? Is she making a voluntary choice? So does she have basic understanding of her health, her potential treatments and end-of-life choices? Does she have subtle symptoms of delirium or emotional distress because of her dyspnea that might result in decision-making that's not consistent with her usual choices? And how much are her wishes driven by depression? Is there any undue influence? Her family was very keen for us to consider this, and they were very, very well-meaning, but how much is undue influence? So those are questions we have on an ongoing basis, and we end up considering how do we decide that she is going to be making an informed, competent decision about MAID, for example, or anything else, which is we start with her decision-making abilities to start with, her capacity, then the knowledge that we need to give her to understand and retain her choices. So she hadn't really been told that if she was able to have comfort care, her medications could be stopped, we'd keep her comfortable. She didn't know that. And so can she get that information, retain that information, and then make informed consent, whatever she chose? And that is affected by her emotional state at the time. She was very dyspneic. Other people might be emotional about something new, some new diagnosis. Does she have some cognitive distortions related to her long-standing depression? Are there external influences acting on her? And it's a truly voluntary decision. So this is the kind of thing we've already been talking about with people that we've been assessing for MAID and prior to MAID for sole mental illness, because we are seeing a lot of comorbidity, especially with track 2 now. So if she has decisional capacity, then what's her main goal? How do we best achieve that? Talk her through how she achieves that. Do they fully understand the options? Does their family understand the options? What if her family doesn't agree? They want something that's different from her. So lots of discussions that we have on a regular basis with the complexity of MAID already. So what happened with this lady is that she didn't know that, you know, there wasn't a discussion about goals of care. We had a good discussion about goals of care with her family. I went to talk to her internist. They all agreed. She's over on 20 different drugs. Absolutely, we can do comfort care. She actually died very peacefully in palliative care a few days later. And I would have had to take away her Dilaudid to make her completely capable to consent to MAID, would have defeated her wish for a peaceful death. So she didn't necessarily know all the options to make the choices that she really wanted to make. So how do we weigh this? We always look at balancing the autonomy versus protection. So in her situation, she's a very elderly lady, lots of stuff going on with her, and doesn't have a long life expectancy. So we might weigh autonomy, her wishes to be peaceful, slightly differently than we might for someone who is a 24-year-old, who's got maybe pneumonia, who doesn't want any treatment, and maybe has also concomitant depression. So our decision making about that continuum and weighing that is going to vary depending on clinical context. And that is why there is a detailed series of 2 documents put out with support from Health Canada looking at interpreting some of those legal issues, the law, in terms of what's appropriate clinical practice. And Mona was the key person involved in those. I had some involvement as well, but these are our documents that Mona is going to talk a bit about. So how is this? So now, let's take us back to what happened before we had MAID. So before we had MAID at all, this is a patient of mine years ago who was 78. I was still doing active inpatient psychiatric practice, including lots of ECT, and he had a lifetime history of bipolar affective disorder. He'd been tried on everything known to man. So he was a patient of the person who shall not be named right now, who was the local expert on bipolar disorder. He had tried everything. He'd been on every drug that was available at the time, mood stabilizers, antipsychotics, and the only thing that worked was ECT, but over time, all he had was depressive episodes, and he would stop eating, he'd have ECT, and he would be better for a while, but those better periods got shorter and shorter. And eventually it was about 2 weeks, and then he would be sick again. And so he eventually told me, he had ECT, he told me that he really doesn't want to continue this. He's had a lifetime of this, he's tried everything, he's done. And so we had a big meeting, family, patient, social work, ethics, the mental health nurse that's looked after him, and we ended up feeling that we would like to support his wishes, but he'd already become a bit more depressed, and that we needed him to be as well as possible before making that decision. So we did one more round of ECT with his permission, at which time he was very clear, not depressed. We got him that probably about a week later, so it's not residual delirium. He was clearly able to express the fact that he wished to have palliation. He did not want to be fed by tubes, tube fed, force fed. He was discharged home with palliation, various family members, and he died about 3 weeks later with support, and it was a very peaceful death. So that was what happens in a very small percentage of our patients who don't respond to anything, that we might consider some of these interventions, which previously then were comfort care, they still are just comfort care, but we are looking to maybe then having broader possibilities for someone like him. So how did we feel about this? We all struggled with this decision. So I don't know what you folks would have done with him. I think we all struggle because sometimes we certify people. We think they're we see them as being very depressed. We could certify them. We could stick a feeding tube in them. We could do other interventions against his wishes. But maybe all of you can think about the cases that you might have seen over the last little while, where you see a few people that try everything and they are absolutely not responding to anything. What do you do? So legally, you could certify him and force him to have ongoing ECT, but is that the right decision? Balancing that with his wishes and other ones of our ethical principles. So then the autonomy protection continuum for someone who, an older person, he again might be more autonomy at that point than protection, whereas if he was a 24-year-old, we'd feel differently for him. So if we compare this to people who have purely medical illnesses, again, these are all real patients I've seen, so the names have changed. So this is a woman who'd been at the cancer clinic, multiple treatments for 10 years. She was tried on many interventions, chemotherapy, you name it. She eventually said she's done. She wanted comfort care, and she actually also had some discussion about medical assistance in dying. So how is that different from Stan? So many of us do feel more comfortable in the initial stages for a pure medical decision, and she is legal right now to access medical assistance in dying if her dying becomes difficult, but how is this different? So there's some differences in that we worry a bit more about the comorbid impact of depression on his decision making. There are a few of those, but there are many similarities as well. So fast forward, if MAID were legal, do we support that for him? So this is what we then think about, what might happen. We don't know if and when it happens, how we will feel about accessing MAID for someone like that, who's actually gone through everything, many, many years of treatment, and he's an older person. How do you ensure he has a voluntary choice, he's not influenced by external circumstances, such as maybe not getting appropriate supports in the community, or his mood state. So this is still going to be a challenge for us, but how do we feel about it? That's what we're all going to start thinking about, because I do think this will eventually become a possibility here in Canada. Different from somebody in a younger person. So here's where context is so important. What about the guy? He was 28-year-olds. What about when he was 28? He'd had 10 years of treatment, had tried all these treatments for 10 years. How do we then deal with him saying, I don't want ECT? And And so 28-year-old, we know that many people take many years to get better. I did a lot of presentations at people with lived experience. So I did some with mental health organizations, and I had a woman said after my presentation, Dr. Thorpe, I have schizoaffective disorder. I'm in my 40s now. If MAID had been legal in my 20s, I'd be dead now because it took me over 3 years to get stable. I was really, really sick and I really wanted to die. So the concern sometimes is that it takes a long time sometimes to really explore the various options for treatments of some of these disorders, and people may yet get better. But interestingly, of all of the presentations, I did a lot of community work last year, a talk thinking this would happen. Most people feel it should be available in those very refractory cases. These were people with lived experience, but very cautiously. So again, the autonomy protection continuum is in a different direction for someone who's young, who has many years left to try treatments that might still come up and maybe not be tried. So just briefly, I want to do an update on what's happened with the law that makes this possible. And I'm watching the time because the people who've been my residents know I could talk forever about this. So David is gonna wave at me when it gets a bit closer. And so just briefly, you've all seen some of these slides of mine, which is that 3 women changed the law. Hey, women rule, it's always the same. And women live longer too. So it has been women. Sue Rodriguez had ALS, I mentioned her before. She ultimately had a peaceful death. We never knew exactly how and who did this, but she was not successful in getting the law changed. Whereas Kay Carter, she was 89. She had spinal stenosis. She had pain, constant pain, and she wanted to access a peaceful death. And she and Gloria Taylor, who had ALS as well, ended up applying for this. This again made its way all the way up to the Supreme Court. And as a result of their work, we ended up getting Bill C-14, which allowed medical assistance in dying for people under certain circumstances, which were people with reasonably foreseeable natural death. But remember, Kay Carter was the woman who promoted this. She was not going to die in 3 months. It was not going to be imminent. She was going to have a few years. So it never said 6 months or imminent. But it did say reasonably foreseeable natural death. It made clear that nobody had to formally participate, that didn't feel that this was right. But if people couldn't abandon their patients either. So, and patients have the right to seek their legal options. So the eligibility criteria were 18 and over. It is not younger people. People are very afraid that this is younger people under 18 will make these decisions. Our patients sometimes and families don't know this. 18 or over, you have to have capacity, decisional capacity for health decision making. You have to be able to give informed consent, which we talked about before, which means a number of things, not just having theoretical capacity, but having the information provided in a way that they understand it and not being influenced. Then the main criteria here are grievous irremediable medical condition, which is serious and incurable illness, disease, or disability. So this is currently not only mental disorder. So something pretty bad that's not getting better, and already have affected that person, so that person is in an advanced state of irreversible decline in capability. So it's not someone in the very earliest stages just still able to do things for themselves. It is a person with really significant impact of that disorder. And they have to have enduring physical, psychological suffering that is intolerable to them, can't be relieved under conditions they consider acceptable. So I've underlined that. Some of you, the residents, have heard me talk about this. This is sometimes difficult because this last bit, because what do we do when somebody doesn't want to try anything? And those were just things we've discussed at our group that worked on those Health Canada, the documents, which I've listed in the beginning there. And Mona will talk more about this. What do you do if somebody doesn't want to try anything that would clearly get them less suffering? And what do we do? And again, that's going to be very context specific. We might feel differently about a 95-year-old woman who might well get better from her dyspnea and suffering with treatment than somebody who's 25. So then, reasonably foreseeable natural death, again, based on K. Carter, people often think that it needed to be imminent death. That's not the case. So, and then this was challenged by two people with disabilities. These were Quebec challenges, and they felt that this was a violation of their charter rights because they would suffer for a long time, and they are still young-ish, and they had suffering that was not going to get better. So that was the origin of C7, the long and the short of it, which allowed for people to access MAID that were not having reasonably foreseeable natural death. You see the acronym up there, RFND. So the government approved this, Bill C7 approved this. This required some additional safeguards. So this meant at least a 90-day period after this happened. So, and so it is not definitely 90 days, but at least 90 days. So there are some possibilities of shortening this if a person is losing capacity quickly, but it's mostly 90 days. There are also, patients have to be connected and told about the various ways their suffering can be relieved. And that might include counseling services, mental health, disability supports, community services, palliative care, and we connect them up with those services. Now this is very time intensive, so it takes hours and days sometimes and weeks to get a person really well connected. And I'm going to show you just some clinical vignettes of how much work this is. Now, in Saskatchewan, I will show you the processes here. We have a little bit easier time because we have a provincialized program where people can work on connecting people to services, so we don't have to do it all. So we're very lucky for that. But it's often very time intensive. So the second part at the bottom here is that we have to involve someone who has expertise in this condition, that we don't have expertise in everything, and we want to make sure somebody can fully give us guidance about what might be available for that person. And at the bottom here is that a patient has to have been given serious consideration to those needs. So it's not automatically you say no, 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 no to everything. You have to actually talk them through and consider those things. So that's in our legal, so that's the law. And those, if we follow that law carefully, will protect people who are track 2. And analogously, people who have sole mental illness who may well then be applying. So there's also a waiver of final consent, which in Saskatchewan is called the ACA, the Advanced Consent Arrangement Form. In the rest of the country, it's called the waiver, but that's only possible for track 1. So it's people who are dying reasonably foreseeably soon. So this will not be one that'll be available to most people with sole mental illness. And so then why we all have to absolutely know about this is that our numbers are increasing. So we haven't got any national figures for 2023, but our MAID manager who's here, Laurie, is going to show provincial figures as well. So we have some provincial figures, but what you see in these little the red bars is people who don't have reasonably foreseeable natural death, and that's increasing as well. So that is going to be that category of person that are going to be most similar to our patients applying for sole mental illness, and that's increasing as well. It's only a tiny sliver right now, and so most of the cases we're seeing so far, cancers, particularly lung cancer, and most of our patients in that middle age range, not too old, not too young. My oldest was a few weeks away from 103, by the way. She said her heart failed. She was living independently until 5 months before, and then her heart failed. She was in a horrible state, dyspneic, lying there massively edematous, and with her extremities all blue and cold. And she smiled and said, "I've had a great life. I'm ready to be gone." And so we've had a few very elderly ones, and a few young ones, but for the most part, these are in the middle age range, but increasing. Now, interestingly, when the law changed, there was much concern that if you only had enough palliative care services, you would not need MAID. That turns out not to be true. And the inadequate pain control, for example, is not the top. The top of the nature of suffering for the patients, this is national data, it's the same for the patients I've seen a lot, is really the loss of ability to engage in meaningful life activities. That's the biggest reason people are stating for their suffering. And then close, loss of abilities to look after themselves. Patients tell me, I can't wipe my own butt. These are very, very hard stuff for people who've been autonomous, independent people. And then less on pain. Most pain can be a bit better controlled, but not always. So I've seen people at the palliative care unit that have had intrathecal pumps and still in agonizing pain, and that have had MAID in the end. So those things have changed. Most people have been found to already access palliative care. So 87% of people who accessed MAID already had palliative care. So it is not the case that if you only had palliative care, you would not need MAID. So we all feel, yes, you should have more palliative care, but it's not the only thing. So far fewer people who are track 2, so not dying quickly, are applying for this, but of those, most of the neurological conditions, the MS, and so on. So I mentioned track 2, much more difficult. This is going to be a lot like we see patients who have primary mental illness. So what I'm seeing is people who have a lot more comorbidity. I've just listed some of my patients I've seen, some of their backgrounds, and what we see is poor social isolation in those patients, decreased normative feedback from others when they're isolated about their thinking patterns, not enough knowledge about what their options are, demoralization, poor self-esteem, poor coping, poor supports, and a lot of comorbid mental disorders. So this category, I think, is going to be similar to what we are going to see, and we're going to need different ways of dealing with that and managing those people's requests. And so mental disorders is what we're going to spend time talking today about a lot of, and is already legal in many places. So the ones I know of, Belgium, Netherlands, Luxembourg, Switzerland, Germany, and Colombia. Is there anything else, Mona? You're always up to date on the latest. She's thinking about it. So those are the ones I know of where it's legal, all for different, slightly differently organized, and the laws are slightly different in each of those countries. And in Canada, this was deferred again. So initially the plan was this would happen in 2021, I think, and then it was deferred for a few years more. It's again deferred. And then, so there's been much discussion about what we do before it does become legal, what need we do to plan for this, and Mona will talk more about this. And so the most recent report has been the joint report here in 2024, January, on MAID and mental disorders, the road ahead, where do we go from here? So Mona will talk more about that. But what we know is that if this happens, this is from European data, most people applying will have mood disorders, depression, bipolar disorder. There are actually a lot of personality disorders as well, so these are the ones many of us worry about managing, especially borderline personality disorders. We see them often, a lot of suicidality, impulsive behaviors, and that's not uncommon. And interestingly, a lot of people with autism spectrum disorder. So these people who don't fit into the world very well and often not treated well by others because they're different. And we all are talking a little bit more about neurodiversity these days and better acceptance of neurodiversity. We're not all the same. And so hopefully that will improve the quality of life in people with some of these difficult disorders. So at least comorbidity is the rule, at least 2 psychiatric disorders in most people. So this is what we know happened in Europe, where this is legal, and we're likely to see similar things here. And however, so all of us worry about how we make this safe. And so what do we do? And I think we already have a fair number of safeguards for people based on track 2. and ways that we should act based on some of the guidelines, the Health Canada guidelines, for example, that will be really a basis for how we can make this as safe as possible for a maid for sole mental illness. So I'm going to take you through a guy that I saw. So I've seen him a number of times now. This is a guy. He's 50, it's not his real name. He's 56, Indigenous man. He's in a homeless shelter. And I get asked to do a MAID assessment on him. And this guy I had met before. So I met him before when he was in hospital. When I'd met him before, he had chronic pain, diabetic neuropathy, he had peripheral vascular disease, already lost a leg, but his pain was well controlled. He was not suicidal at the time. He occasionally had some depressive symptoms. We started him on escitalopram at the time, and he was actually quite stable. He had renal failure on dialysis. So this guy, very sick guy. So he was in a hospital for quite a while, City Hospital. He then got discharged, ended up homeless. So this guy, no family doctor. He ended up at a homeless shelter, no family doctor. When I met him, I went to see him there at the shelter. He was on no medications. He occasionally had enough money left to buy Tylenol from the drugstore. That's all he had. He was not on any insulin, no significant pain medications, which he had been on before. He was on pregabalin before. He was actually quite managed. He was on nothing, and he actually didn't even know that there was a nurse practitioner coming every week and a family physician every second week to that shelter that could give him some care. So he'd heard about MAID. It was very much talked about everywhere, and he asked for MAID. I talked to him. He had no idea. So didn't know, so is he eligible for MAID? So is he eligible for MAID? We take him through everything. So he's 18, yeah. Does he have capacity? It's a bit questionable. He had some knowledge deficits. This guy didn't have much education. He didn't know much about what was available to him, but with enough help, maybe he could make his own decisions. Could he make a rational voluntary request, not as a result of external pressure? So the external pressure in that case for him was lack of access to resources and a lot of pain. So how rational, how stable is his request? How much is it affected by this guy? Did have a history of depression, demoralization, psychosocial circumstances. So voluntary requests, voluntariness, questionable. Does he give informed consent? He actually didn't have all the information. You need all the information to make an informed consent for MAID. He didn't know that he could actually get some access. So I was able to connect him with a nurse practitioner there at the shelter. The manager at the shelter actually was great. She connected him up. She got him set up with the family physician that came every second week. And so what I said is that I did not think he was eligible for medical assistance in dying. He did not have fully informed consent about all his options. The major precipitator of his wish for MAID was the fact that he didn't have access to care at that point. It was very much precipitated by psychosocial circumstances. This is not the medical disorder so much by itself, because he was going on without it before. So we think about, so I've put this up, the Physicians and Surgeons of Saskatchewan has some really nice information on capacity and informed consent. So looking through that, following their guidelines, so we're going to hear from the college this afternoon, but if you go on their website, they actually have really nice things on there, the college, and particularly about capacity and informed consent. So based on following their guidelines, really he could not be said to have informed consent at that point. So I'll skip through this a little bit, because we're going to go back always with every one of our decisions. Does he have the cognitive decision-making capacity? I think probably he could have with enough help. Has he been given the right information to make all the choices he needs? Actually not. So he didn't have all of that. He was able to retain it, but he didn't have it at the point. And then what was his emotional state? He was in very significant pain. This guy was in a wheelchair. He was in pain continuously. So he was really quite distressed. He had a state of emotion. His emotions were not in a state to make really good informed decisions. And external influences might not always be purposeful, but they might be things like not having access to services, which might be an influence precipitating his decisions. So there's a bit of argument about how you consider undue influence, but many people do think that not having access to services is really an influence that might not be something that should be driving this decision. How voluntary was his decision? So we go through this, and we often end up having to consider this. When vulnerable people in particular are involved in asking for aid, what is vulnerability? So is a person at risk of doing things such as requesting receiving aid or ending their lives by suicide, for example? They may be vulnerable people, so they might have personality factors, poor coping skills, mental disorders, pain, trauma history, and then maybe some coercion from others, family members that feel that the personal care home is very expensive and they're putting some subtle influence on that person not to live too long because they can't pay for the personal care home. We see this in our regular practice. Vulnerabilities might influence some of the choices people make, and people really are not eligible if the vulnerability that's incidental to their condition is the main cause of their suffering. So that was one of our teaching guidelines, that modules that we're using to teach this across the country. What it concluded, that this vulnerability, in this situation, a person is not eligible for aid. And these modules are being rolled out across the country to make sure we have standardized teaching for people across the country that's consistent, because when we start out, every province had somewhat different interpretation and patterns, and that's still a bit the case. But so sources of vulnerability, just mentioned some of those: the capacity that the person has, the cognition, coping skills, trauma history, low self-worth, I'm not worth living, negative interactions with the medical system, don't want to deal with it anymore. And then previous abuse history. So access to their own support, socioeconomic things, and stigma, racism, and so on. So there are many things that can make our patients vulnerable, and our mental health patients often are vulnerable. We worry about their vulnerabilities, which is why it's important for us to talk about these things. And so I'm going to go back to Bob. Here is Bob. So serious incurable illness, yeah, he has terrible stuff going on. So he certainly has incurable illness, diabetes, peripheral vascular disease, renal failure. So that's true. So he has that. And then advanced state of irreversible decline. So irreversible decline, does he have? Actually, he's never going to get his leg back. His diabetes is not going to get better. How do we know if he can become more, maybe he would become more mobile if he had less pain, so you're able to mobilize more, get around to do some things that are positive. So we worry a bit about that, but for the most part, his decline capability is probably not going to get better. The suffering would be the biggest issue, because intolerable suffering, this guy did not show much suffering when I met him previously in hospital. I think it was about a year and a half before that. He was on his medication, on his pregabalin, he was getting his insulin and so on. So is the suffering really manageable if he had access to services? Actually, possibly, very possibly. So this is very well may not be irremediable suffering. This may be largely due to lack of access to medical care. So that's what happened with him. What are the means available to relieve his suffering? how reasonable would it be for us to go ahead with something like medical assistance in dying when we don't try getting them connected? So we were able to find resources, and it was not very difficult in that situation. In other situations, it's much more time intensive, and we're grateful to our provincial MAID program, who has social workers involved that help with this and often have helped with this. But these are things that are going to become increasingly important with MAID for Soul and Mental Illness as well, at which point we'll need more staff that probably will help with some of the psychosocial aspects of the illnesses as well. So who would have the expertise? So we often have questions about what does expertise mean. Mona will talk more about this. We talked about this in Health Canada guidelines. So for psychiatric illness, should it be a psychiatrist always? Should always a psychiatrist be involved if it's a patient applying for soul mental illness? So there's some discussion about this. When we had discussions across the country about this, some areas of the country don't have access to psychiatry, and there may be a nurse practitioner who is the main person supplying psychiatric care, or a registered psychiatric nurse. So, and there may be a family physician who actually is very skilled at providing some resources. So expertise probably may not necessarily have to be a psychiatrist, although this is controversial. Some people feel it should be, but some areas of the country would have very little access to that. So it's a bit of discussion. Mona might go into more about this. So other questions we always have with when we look at eligibility: what if they refuse access to health records? We see this in people who are quite paranoid. You don't let us want to access health records or talk to any family members. I did an interview the other day with someone who let me talk to his daughter only, but there are multiple other family members, an ex-wife, there are other children, but he didn't give access. What do you do? What do you do if you need that information? That might be important to you. So the practice standards talked about that, and if we can't get the information that is necessary for us to do an assessment, maybe we can't find that person eligible. So difficult discussion. So same with collateral information for him. And then I'm actually going to finish fairly early, so we have lots of discussion time. Now, dementia is in that borderline where we see it as something that fulfills within our work as psychiatrists, and many of us in geriatric psychiatry deal a lot with behaviors related to dementia, but is also a medical disorder. So right now, dementia itself is considered a medical disorder, and people may well be eligible for MAID based on a dementia. So it is a serious incurable illness. People in the later stages are in an advanced state of irreversible decline, but do they have capacity for informed consent? Only earlier in disease or in the maybe intermediate stages. Are they suffering? Often a lot when they're still aware they have it, but later stages, as I've had people who we've approved for MAID for dementia, 6 months later, don't actually know they have dementia, and they're quite happy. And I don't have dementia, I don't want to die. So challenges with dementia that are coming, a little bit of an overlap with us in psychiatry, but right now it is something that some of us will end up faced with. How do we assess somebody who's applying for predominantly dementia? So we're not going to talk about these, this is practical issues. We're going to talk about after 11, I think, what time? So at 11:15, we're going to talk a little bit about how this happens in Saskatchewan. All of you here are working in Saskatchewan. So there are differences across the country, how each province deals with medical assistance in dying, as they will be in medical assistance in dying for soul and mental illness. So what we're going to be talking about is what we're doing so far. That we'll do that at 11. Laurie Brad Richards is here, who's the manager of the provincial MAID program. And we're also going to talk a little bit about what some strategies might be to approach patient requests who are requesting for soul and mental illness. So we'll talk more about those practical issues. So what I want to do now is, I've talked a lot. Let's just have an open discussion. Any thoughts? Or has anybody had contact with a patient in emergency or anywhere else who's been asking questions about medical assistance in dying? an ER or in your practice regularly? Anyone feel up to? Yep, Adam.
I have one patient right now in my outpatient clinic who's been struggling with chronic depression for many years, suicidality, tried multiple treatments, and now is strongly considering MAID, but just started asking that question over the last 6 months or so, not fully wanting to commit to applying for it. So yeah, it's just one situation that I've been dealing with. And with this case, I've been kind of encouraging him to talk to his family, figure out for himself what's going to be best overall, and then we'll have a more firm discussion when he's actually decided yay or nay.
Mm-hmm. Interesting. By the way, we have some online people, right? Because we have a microphone. You have a microphone here? Okay, wonderful. Okay. Yeah, so maybe we should use the microphone for anyone from here, just to make sure our online folks can hear what's going on.
I had a quick question. Thanks very much, Dr. Thorpe, for that presentation. I was just wondering when, very rarely will a patient in my practice bring this up, but on occasion they would, and sometimes it's, even though I'm not really up on all of the latest criteria for eligibility, it's pretty clear to me that they would not qualify, but is it still reasonable to, give them the information and tell them to self-refer and then they can kind of go through the process, or should we be kind of discouraging and saying them, to them, really, I don't think you would qualify at this time? Like, what would be your approach?
Mm-hmm. So I think anyone who asks has the right to get all the information, and you can give them all the information that you have, but we do have a provincial program that's got a number that's easily reachable for anyone. So after 11 o'clock, we'll show that number. I have it up on a slide. So I think we can encourage our patients to connect with that provincial number, because what they will do is they'll get a nurse who's up on things, who will connect with them. They can send them quite a bit of information. They email a lot of information to people. There's also a web page. So I think if somebody's asking it and they look like they have reasonable questions, you can tell them that you think it's not, they're probably not, but they may want to follow through with a provincial program. There are things that change over time as well, so they may benefit from having that information provided to them. Often just knowing that there might be an option down the road is very helpful to them. So we don't discourage them, because we want to make sure people have full access to information. The law actually says that it's illegal to block people from access to legally available treatment. So some of you know there was a situation not long ago where a person, it was not a physician, said, why should they bother getting involved, because this person's going to die anyway. And so we actually all need to be respectful of our patients, whatever they ask for, and I think making them in touch with the appropriate numbers is the thing to do. So they'll get a call back and they'll get information sent to them, and just that is often very helpful.
Okay, I have an online question here. Are there any mechanisms/processes in place for patients presenting to the ER and requesting medical assistance in dying?
Can you just read that one more time?
Sure. Are there any mechanisms/processes in place for patients presenting to the ER and requesting medical assistance in dying?
For primary mental illness, was that what that first bit was?
It just said any mechanisms or processes.
Okay, so if they come through emergency, they could be given information that they could contact. They wouldn't, so MAID isn't an emergency service, so there are very few people there who are involved in that. So we do in Saskatoon have some on-site people, but they can't be there at any hour of the night. So through emergency, 3 in the morning, there wouldn't be anyone that would meet with them, but they could be given information about MAID and the number for MAID. You can Google this and find it out as well. So it's probably worthwhile in emergency for people that information to be available to patients to phone, but it would be not it would not happen that someone would meet with them at 3 in the morning about MAID. That wouldn't happen.
Thanks, Dr. Thorpe, for the interesting talk. I just had what your comments would be on, you mentioned this continuum of autonomy and versus protection, and also how for track 2 and non-foreseeable death, that, you know, when does that, as care providers, do we bring, is there an obligation to discuss MAID as an option as part of palliation? Because that's a question I think often comes up from non-psychiatrists too, for MRPs who are on internal medicine units, general practitioners who they have a patient who might be contemplating it, but or is suffering and or nearing end of life. So just what your comments with that would be, or how we might approach that subject. Do we offer it or not? What is our obligation to do so?
Yeah, so we as healthcare providers have an obligation to disclose to our patients reasonably available treatments consistent with their clinical context. And so there's more well-worded stuff in the Health Canada documents on this. But if somebody clearly is in a situation that they may not be aware of access to some services, such as palliation, such as comfort care, such as medical assistance in dying, when we present options to our patients, it is our obligation to present the various options. Now, if one had a strong objection, conscientious objection to MAID, you might say, so there are options with medical assistance in dying. If you are interested in that, I can connect you up with someone else who can tell you more about that. So most of us feel that the appropriate response is to share options, but to ask first. So what I would recommend is that we say, sounds like things are really difficult for you right now. Would you like to talk a bit about various end-of-life options? There are a few of them. And say yes, then I would go on to talk a bit about the various stuff, such as the decreasing medications no longer beneficial, looking at comfort care options, and medical assistance in dying. So it is contextual, though. So if somebody discloses to you they're a very strong Catholic, that they, right up front, you know that this is going to be uncomfortable with them, you're going to be cautious with this. But it is our responsibility to provide the range of options that a patient might need they may not know about. As the 95-year-old woman didn't know she could have comfort care right there. She died, her family didn't know either. But people don't know about MAID either sometimes. We still see people who don't know. And so especially if they're saying, this life is terrible, I know it's not getting better, I would really like a comfortable death, and they don't know about MAID. Most of us feel there's also an obligation to say, do you want to talk about those options? And if they do, talk through, including MAID. That answer that? Yeah, and I think Mona might talk more about that at with the Health Canada guidelines, because that was a lot of discussion. When do you raise it? The issue with raising it not carefully is that we don't want patients to think that we are promoting this or encouraging this or think this should be gone as quickly as possible because they're causing us difficulties. So we have to be careful how we raise this, and some areas are not supposed to raise it. Some professional organizations, I think psychiatric nurses or licensed practical nurses are saying they're not supposed to raise it. Nurses are allowed to raise it, RNs, we are allowed to raise it and probably should be in the right context. But we have to be careful how we raise that.
Thank you very much for a great talk. As always, I struggle to reconcile what you said in your earlier slide about having access to an expert opinion and the fact that you said you don't need a psychiatrist, an MP, or there may be a consideration that you don't need a psychiatrist, a nurse practitioner would be enough to offer an opinion. I struggle to reconcile those. Mm-hmm. And the other question for me, isn't the absence of psychiatrists or psychiatric services led by a psychiatrist or involving a psychiatrist a vulnerability factor? If I was in a car load where you have only a psychiatrist flying once a month from KMH or Ottawa, am I not vulnerable?
Yeah, so this is, of course, what there's a lot of worry about. So somebody who self-assesses themselves as an expert may not actually be a real expert. So what we will talk a bit more about later in the morning is looking at involving psychiatric expertise, possibly in a way that is not so time intensive to some of those specialists, so that one might be able to get some opinion based on the presentation of a person from a specialist in the area that is not necessarily seen that person but has access to all the information that could at least say, this is what I think is necessary. And so we are all thinking about ways in which we can make that happen, because I agree that there's concern about people self-diagnosing themselves as an expert as well, but there may be ways around that. We've all got better about doing virtual assessments lately, and during COVID we got pretty good at that. So my thinking, and we'll talk more about this later this morning, is that there will be some subspecialists lined up that will be in agreement to help with some guidance. They may not be able to see that patient, but they could at least provide some guidance to a complex case team that then might put all the information together to start with what services they've had, what have they tried, what treatments they've had, who assessed them, and that they could at least then guide the process from that point onwards, so that we don't end up with someone considering themselves to be an expert who may not have expertise in that area. So none of us are experts in everything. Like I think I don't have good expertise in chronic psychotic disorders anymore, and so I would not want to be the expert making that decision. So, but you're quite right, some people might self-assign themselves as experts. That might not be, but that is a worry. And so we're all talking about that across the country. How do we make that happen in the light of shortage of psychiatrists? There may be ways that we can get creative to do that. And I think we'll have lots more discussion after between 11:15 and 12 on that.
Good morning. My question's a little bit more about numbers and rates. And I'm wondering, with the rates in Canada year to year, it's going up. Would it be expected at some point there will be a leveling off? And then how do rates in Canada compare with other countries, and if they're different, is there any explanation, although it's hard to compare when Canada is still on the move?
Mm-hmm. So it's a good question. So are we expecting rates to level off? So I think so we're increasing rates right now. This is a new legislation, relatively new. I mean, if you look at most people in practice right now, never even trained in this, when they had the lectures, it wasn't available then. So it's pretty new. And so when things are new, things will increase for a while. So my expectation would be that it would level off, and in other countries that have had made available, it doesn't look as if it's going like excessively to 80%, 90%, the whole population. There does seem to be a pattern, and I guess we will see, because we're in the early stages of this, what will happen with that. And I don't know, Mona knows more of the international stats. And Mona, did you want to comment on that? What in the European countries that have had that, what's happened with the numbers? Because my sense is that they're not exponentially increasing anymore. Is that right? So Mona was saying that it has been leveling off. That was my sense the last time I looked at stats from elsewhere.
Hi, thanks for your talk. I obviously, we all wish that we lived in a place where everyone could access all of the resources that they need. So I'm not necessarily, it's not a bad thing that this is a good way to get resourced, but what I anticipate is a lot of people coming in, especially to the Emerge, saying, if I don't get what I want MAID, or nothing has helped me, I want MAID, and almost using it as a way to get resources, which obviously they need, but maybe don't need for this purpose.
Yes, and so people are going to use MAID as a threat, and we are seeing that people are saying, if I don't get something, I'll just get MAID. I had yes, I've seen cases like that. So Now, there's also concern that people saying that shouldn't leapfrog over others who are on the waiting list. So one of those mental health meetings I had, actually I've heard this a few times now, people saying, so just because I've been waiting for 2 years to get a psychiatrist, just because somebody applies for MAID, are they going to jump over me and get it quicker? And I don't think so. I don't think we should be doing that. And I think, fortunately, you know, we should not be doing that. So that is an issue. But I did have, so I'm going to try to do this in a way that doesn't breach confidentiality. But I had a guy who threatened for years to end his life by suicide if his wife didn't take him back, because he was not a very particularly nice guy. And so for years he threatened this, and she'd take him back. She eventually said she wasn't taking him back. He then asked for MAID, and I did an assessment on him. And he that's what he told me too. He wanted MAID if his wife doesn't take him back. So, you know, he didn't fulfill MAID criteria. I made sure he had a mental health nurse. He did have a mental health nurse. He actually had a psychiatrist that came into his region. And I said, you know, that's not a reason for medical assistance in dying, that your wife is not taking you back. And so we wouldn't approve you for that. And he ended up his life, he hung himself, actually. And he had all kinds of resources available to him. You couldn't have done anything else for this guy. But again, a threat for MAID, the threat itself isn't a reason to do this, somebody threatening. Now, we've also had people threaten us by reporting us. So quite a few of us have been reported to the college by not approving a particular person. And so I don't know how many, last count, 5 of us maybe, or 4. Lori, 4 people. Lori knows this case very well. And so, I mean, so this guy, you know, he's got very minor medical issue, better off than most people, no impact on his functioning, and I said no. My colleague said no. 2 more colleagues said no. So I got reported to the college. So I save all my files, so I always teach my residents, if you don't write it down, it never happened. So you track what you do, you write everything down, you track your information, and I sent it all to the college, and the college looked at it. It's painful when someone complains about you, but the college said, no problem, we have to follow the law. So it's a threat. And I don't know if that's happened to anyone else other than that patient. Lori knows. So the advantage of having a provincial program now, we've had since late 2018, is that the information is all collected, and centrally it does make life easier. So then you have central repository of that information, and we're better able to know what's happening. But that is always a threat. People are mad at us when we don't do what they want us to do. So I anticipate that people with personality disorders that are going to ask for MAID might be very difficult for us. And so I know that right now there are a number of people in that situation who have been quite difficult with the frontline MAID staff. And so, yeah, there'll be challenges coming up. And so I think this all means we have good processes that are clearly laid out, and we make clear that we follow the processes, and threats do not make us deviate from agreed upon processes, which we all develop in order to keep our patients safe and to follow appropriate, responsible practice patterns. Do we have any more online questions? Or we get a nice long coffee break? What do you think, guys? What do you think, David? You know, we booked this for 10 o'clock, but actually what we could do is have people have a slightly longer break, or start later for the next one, or earlier for the next one?
Yeah, we're about 5 minutes ahead of schedule, so we can start break early if there are no other questions at this time, and reconvene for Dr. Goodman's talk.
And we could still discuss things informally here. Some people are always happy doing it informally, not in the big forum, and that's okay too, especially if we have a long coffee break. You got one more there?
No.
Are you, no? Okay.
Nope, just checking.
Okay, so then we'll have a coffee break. And what time, David, do you think we should get going as scheduled then for the next session?
Yeah.
10 o'clock?
Yeah.
Okay. All right, so coffee time. And where coffee would be out here, in the back.
Hello. Sorry to interrupt everyone's coffee break. Hopefully everyone had something to eat as well. Refreshments at the back. That'll be there throughout the day. But it's now 10 o'clock, so we'll move on to our next speaker. And I'll just give a short introduction of Dr. Mona Gupta. And also, full disclosure, I cannot speak any French at all, so I will have to introduce you in English only. So Dr. Mona Gupta, who's so graciously came from Montreal, and she's an associate clinical professor in the Department of Psychiatry and Addictology at the University of Montreal, and she specializes as a psychiatrist and bioethics researcher. And she completed her medical education at McGill and then residency at the University of Toronto, where she also obtained her doctorate in bioethics. And her areas of research include bioethics and philosophy in psychiatry. She also chaired the Canadian expert panel on MAID and mental illness, as well as the task group on MAID practice standards. So please welcome Dr. Gupta. Thank you.
Good morning, everybody. I had to travel all the way to Belgium to meet Lillian Thorpe, and I was very glad to have done so. So when David wrote to me and said, I'm organizing this event and Lillian's going to be there, I immediately jumped to book my flight on Air Canada, which might have slightly thrown a wrench into the works, but fortunately all's well that ends well. I want to tell you right away at the beginning why I have an asterisk next to mental illness, and that is because despite numerous expert recommendations to the federal government that they speak about mental disorders, which is the terminology we use clinically, rather than mental illness, which doesn't have a standard definition, the federal government chose in the latest, well, actually in all of the references to mental something in legislation to use the word illness. So I'm going to adhere to that term today. We can have a conversation about what that means actually, and in more specific and clinical terms, when it comes to the exclusion, what is actually included and excluded by the use of the term mental illness. It wasn't an oversight, it was intentional, but that doesn't make it less vague. So I'm just interested to know how many people have been sort of following the evolving debate about MAID, particularly as it concerns people with mental illness? Great, yeah, I just don't want to repeat a bunch of things that you already know. Those of you who have been following it even from a bit of a distance will know that a lot of the public conversation has been about the new processes, mechanisms, structures that need to be put in place in order to accommodate MAID requests from people whose mental illness is their sole underlying medical condition. And that's really what I'm going to speak to today, following Lillian's excellent overview of the issues. I'm going to get into sort of the details of what kinds of processes, mechanisms, clinical practices have been reflected on, recommended in order to accommodate these kinds of requests. So I'm a consultation liaison psychiatrist, and I must say that I encounter hard cases almost every time I'm on service. Some of these cases are complicated in ways that have nothing to do with this presentation, but some of them are. So for example, and this isn't just me, our service gets consulted because we're a transplant center. When people make acetaminophen overdoses, massive acetaminophen overdoses that go into hepatic failure, so we'll be consulted urgently about whether somebody should be placed urgently on the transplant list or not. We also get involved in all of the very challenging treatment refusal decisions where refusal is likely going to lead to death, and most recently it was a gentleman with chronic, it's hard to know if it was treatment refractory or not, but had not been treated for a long time, so probably refractory and eventually lost to treatment, schizophrenia. So somebody who was pretty marginal with a lot of social isolation and negative symptoms. So sometimes I don't know what's going on in these cases or what to do, but I have an overall approach to the situation to know how to get help. So which of the colleagues to go to, which resources I can draw upon so that I can respond to the referring physician and ultimately the patient. And the thing is that I'm not going to a law. to figure this out. There usually aren't any laws that are there to tell me what to do. But nevertheless, we've all learned an approach of what to do when we're faced with complicated cases. And so this is going to be a recurring theme in my talk today. Yes, there is specificity to the practice of MAID, and there is specificity to the practice of MAID as it concerns people whose mental illness is their sole underlying medical condition, and we should certainly respond to that specificity. But MAID also exists within the larger structure of medical practice that already directs us and set boundaries on what we do, what we can't do, and how to do it. So maybe we don't actually need, contrary to what has been said in the public debate, to invent a whole separate parallel structure to accommodate MAID requests by people who have mental disorders, but rather to harness the structures that already exist and take advantage of their full power. So hopefully this will become clear as I go on today. So I'm going to speak very, very briefly because Brian Salt from the CPSS will be here this afternoon, who will be able to speak in much more detail about legal and legal issues and jurisprudence, but I'm just going to give a very brief overview of what the courts have said, what little the courts have said about MAID for persons with mental disorders, mental illnesses. Then I want to focus on the principal concerns that have been raised about this particular subgroup of MAID requesters and how these concerns have been addressed, or what recommendations have been made to address these concerns. And Lillian has already surfaced, I think, the main concerns that come up in clinical, in political, in lay conversations about this topic. I'll speak briefly about some additional mechanisms to support good practice that provinces, territories, local health authorities can draw upon if they wish. In other words, we do not need to wait for the federal government to say, consider this or do that or put this in place. It's something that provinces, territories, and health authorities are empowered to do now if they want to. And then I'm going to finish with some case examples, some real cases that I've been involved in. So I do assess MAID cases, but in my particular institution, I'm more often involved as a consultant. So there's already 2 physicians involved in the case, but they want a psychiatrist for the reasons that I'll show you in my case examples. Okay. So, do people remember the period between the Carter decision and the adoption of C-14? There was a period of time there where people were allowed to go to court and present their request for assistance in dying because the court had struck it down, the prohibition on assisted dying, but there was no legislative framework in place yet. And during that time, some number of people went to court and said, here's 2 doctors' reports that say I meet the criteria laid out in Carter, and I would like the court to approve my application. And so have you heard of the case of EF? Does that ring a bell? Okay, good. So I'm not telling you things you already know. So EF was one of those people. And EF was a woman in Alberta, with severe functional neurological disorder. So I don't know, because I've never seen her medical record, but what is on the public record is that was her primary diagnosis. So this was the closest thing we have to MIS-UMC. And she, like all those other people, went to court, and her application was approved. Canada chose to appeal her application and went to the Alberta Court of Appeal. On the grounds, there were 2 main arguments, but one of the arguments was that this was an MIS-UMC case and therefore should not have been approved. And the Alberta Court of Appeal unanimously said, persons with psychiatric illnesses are not explicitly or inferentially excluded if they fit the criteria. Lillian has already mentioned the case of Truchon and Gladu in Quebec. And the reason why the mental illness issue came up indirectly in Truchon and Gladu, because Canada, when they presented their evidence, said, look, you cannot strike down the requirement that a person's death be naturally foreseeable, because if you do, people with mental disorders as their sole underlying medical condition will then be able to have access to assisted dying, and that's going to lead to all sorts of harms. So that was a big part of the argument that Canada made in the court in this case. And so neither Truchon nor Gladu themselves were MIS-UMC cases like EF. But having heard all of this evidence, the Superior Court judge wrote, "Last, it bears repeating that neither Carter nor the federal legislation at that time," so when EF was decided, C-14 hadn't been adopted yet, but by the time Chouchon Gladu happened, C-14 had been adopted. "Neither Carter nor the federal legislation excludes people with a psychiatric condition from requesting and being granted medical assistance in dying like any other Canadian who meets the legislative requirements. These people are therefore eligible, regardless of their official diagnosis, once they are deemed competent by 2 independent physicians and meet the other legal requirements." So my read of these 2 statements is essentially these 2 courts are saying to us, this is not a legal problem. The question is not whether this is allowed in law. The question is whether people with mental illness as their sole underlying medical condition can fulfill the eligibility criteria. And since it's up to clinicians to make this determination, it becomes a clinical question as to whether somebody with a mental illness as their sole condition can fulfill those eligibility criteria. But of course, whatever clinical determinations we make as a clinical community have to be consistent with legal norms. So for example, just to take a silly example, we can't invent a new definition of capacity because there's already well-established norms about what is treatment decision-making capacity, for example. So we as a clinical community can come together and say, well, somebody could fulfill the criteria in these ways and not in these ways. The other thing, and I think Lillian's case examples and my case examples also, but I think her well-developed case examples illustrated really well, is that people with very significant psychiatric comorbidity or with conditions that are complex to assess, and I think clear example is chronic pain conditions, are already making requests and accessing MAID now. So I think we need to ask ourselves 2 questions. 1, what are they doing? What are the specialists and the assessors in these cases doing that enables them to arrive at a decision about eligibility or ineligibility in these very similar kinds of cases? And I think the other question, and this is sort of where I started my talk today, what are we just doing now when we're faced with complex clinical cases, some of which involve life and death decision-making? So contrary to what has been claimed by some in public debates, an enormous amount of work and reflection has gone into thinking about the concerns that have been raised about MISUMC and how these can be addressed, both in terms of what kinds of policy modifications are required and what kinds of clinical practices will give us the tools that we need to do this work. So in this section, I'm going to talk, as Lillian pointed out, about the 2 major reports that have tried to advance thinking on this topic. So Bill C-7, which was adopted in March of 2021, required the creation of the expert panel on MAID and mental illness. And at that point, the mental illness exclusion was to last 2 years, and the panel's mandate and its purpose was to recommend safeguards, protocols, and guidance for MAID and mental illness. So the first thing that the panel did was to say, why are we here, right? What are we trying to make safeguards about? And that required us to turn to the professional, political, public debates and say, what are people worried about? And the main things that they are worried about are the concerns that Lillian's already articulated for you, concerns related to the clinical assessment of MAID requesters, whether their condition can be considered to be irremediable, whether these were forms of suicidality, whether they had decision-making capacity, and how to assess their suffering in 2 respects. 1, could somebody with a mental illness give a reliable account of their own suffering? And 2, is the suffering from a mental illness really the suffering because of other social problems? And I want to just make a parenthetical statement here to say that the term irremediable requires no definition from us. It is already defined in the Criminal Code of Canada as being a grievous and irremediable medical condition is a serious and incurable illness, disease, and disability. The person must be in an advanced state of irreversible decline in their capacities, and they must have intolerable suffering that is enduring and cannot be relieved by means acceptable to the person. So we're not actually looking for a definition of the word irremediable when we do our clinical assessments, but rather how to operationalize these three concepts: an incurable condition, an irreversible decline, and unrelievable suffering. So these questions that have been raised by people about the triad of irremediability, about suicidality, capacity, and suffering are legitimate concerns. But of course, they're not unique to people with mental illnesses, nor are they relevant to every single person with a mental illness. So what the panel took from that, and the panel started working in the fall of 2021. So track 2 had just come into effect in March, but nevertheless, we were able to get some feedback from assessors on the front line, people like Dr. Thorpe, who were already receiving requests in this new track. And as Dr. Thorpe has pointed out to you, it turns out that many of these concerns show up in a range of complex cases in track 2 and even in track 1, it turns out. So what the panel said was, well, look, if these challenges are not unique to people with mental illness, what we need to do is worry less about the person's diagnosis and focus more on responding to the challenge. So yes, it is a really good question. How do we figure out whether certain kinds of conditions are incurable or not? But those aren't just mental illnesses. There's other kinds of conditions where the same problem raises its head. So that's really what led us to conclude that legislative change relating specifically to mental illness as a sole underlying medical condition was not the best policy solution. If clinicians were already addressing these complexities in practice, how were they doing it? Legislative change, I want to point out, that speaks only to mental illness as a sole underlying condition also misses out on the complexity found in other types of cases. So if we're really concerned about social vulnerability, we should be concerned about social vulnerability anytime it arises, not just if the person happens to have a mental illness. People on dialysis can be homeless, as we saw in one of our cases. People with cancer can be very poor. People with Parkinson's disease can lack access to services. So these issues are legitimate issues, but they're transversal. And I think as we needed a judge, we needed somebody from another field to remind us not to use diagnosis as a proxy for the issues that worry us as clinicians. So what did the expert panel do in the end? So the issue that, sort of one of the main issues that the panel struggled with is that if we took seriously these concerns that were being raised, and which were about the assessment of eligibility, clinical assessments, what was actually happening in these clinical encounters that led to decisions about eligibility, and were they rigorous enough, were they being done properly to take into consideration these issues? These kinds of recommendations about dealing with these problems, I should say, or these kinds of clinical problems, can just not be written into the Criminal Code of Canada, because that, if those follow the debate, recall, there's like a lot of interest and appetite for legislative change. It's simply too blunt an instrument to contain the kind of specificity and detail that people were calling for. And the best example I always think of when I think about this issue is the Mental Health Act, which is not called that in Quebec, but I assume it's called something like that in Saskatchewan. You know, when I'm in the emergency room or on the ward and there's a really difficult case in terms of whether the person meets the criteria for involuntary hospitalization, the last place I can go for help is the Mental Health Act, because that's not going to tell me what to do, how to figure out my way through this complexity. I need something that's more sophisticated, more nuanced, and more specific than that. So the panel said, look, if we want to say something that's clinically useful to the people who actually have to do this work, then we have to think about the other kinds of policy instruments that are available apart from legislation that can make this happen. And of course, MAID existed already, and that means that MAID was already being structured and controlled through a variety of policy instruments beyond the Criminal Code of Canada. So a variety of federal and provincial laws that are complementary. So for example, in Ontario, the Healthcare Consent Act would be a relevant piece of legislation. The standards produced by regulatory authorities, not just their MAID standards, but their standards on informed consent, their standards on documentation, their standards on confidentiality. Professional associations producing guidance and guidelines for clinicians, and local health authorities who were developing pathways and processes for accompanying people from the point of making a request through the process. And so this is what our legal scholar colleagues refer to as the polycentric model of regulation. You have multiple pieces coming together in order to fully regulate a specific, in this case, a specific clinical practice. So the expert panel made 19 recommendations in total, but 12 of these were specifically clinical in order to respond to the concerns that were being raised about eligibility assessments. And I won't read the slide to you, but they were meant to respond to the concerns that were being raised, and they were also aligned with practices that are in place in jurisdictions where people already can have access to. In Europe it's called, in Belgium, Netherlands, Luxembourg it's called euthanasia or assisted suicide. In Switzerland and Germany it's called assisted suicide. So these were aligned with what was happening in those jurisdictions as well. And I think the most important thing that the panel said, because we knew that there was a strong appetite for rules, okay? That was something that was very predominant in the conversation. There has to be somebody telling us what to do, and we can't diverge from that. So we said, look, who is uniquely powered to tell physicians and nurse practitioners what to do, what they can do and what they can't do? That's the regulators. So we said, put all these recommendations in regulatory guidance. The regulators can ensure, because that's their authority, that people will adhere, and it actually falls squarely within their mandate, which is guiding the profession, physicians or nurse practitioners, to safe practice in the public interest. So the problem, of course, is that this is Canada. And all provincial and territorial regulators for both professions are independent of each other, so that makes 26 different regulatory authorities. They do not develop standards together, and at present have not a single common standard, including for practices where you would expect very little regional variation. So, for example, informed consent, which is highly legislatively dictated, even there, all the regulators have their own standards. And furthermore, they almost all already had a MAID practice standard. So the idea that they were, having never before done it, going to come together and develop a single standard that was going to apply to physicians and nurse practitioners all across Canada was not looking very likely. And this is why Health Canada convened the task group. The task group's job was to do exactly what the panel asked somebody to do, which was to take the clinical recommendations and put them in a form that can be used by regulatory authorities. And of course, there's no way to force anybody to do anything. The idea was to make the document useful to these regulatory authorities. Maybe it would save them time because some of the text was already written. Maybe it would save some of the smaller regulators money, then they wouldn't have to put together their own committee. You make the documents useful and hopefully attractive, and then they adopt them. And then we start to move towards greater harmonization of MAID practice in Canada. The other thing, of course, to do to make something attractive is to get people involved in the process so that they feel some ownership on it. So the task group, which Lillian and I worked on together along with 4 other colleagues, our task was to take the expert panel recommendations, put them into regulatory language, and say to the regulators, here you go, here is what we think is a MAID standard that can respond to all kinds of complexities, by the way, including the complexities that arise in MISUMC. What do you think about this? So they participated, ministries of health participated, and clinical communities also participated in giving feedback to this draft. This will be relevant when we get to the part about the question that was raised about who should be the expert and why psychiatrists aren't named explicitly. We took that feedback, which was quite voluminous, we redrafted the standard, and then we disseminated it back to the regulators. After that, it was then up to each of these 26 individual regulators to decide what they were going to do with it. And when I talk about the advice the task group said, I'm going to show you how the CPSS, what they did with the content of the standard and how they integrated it into their own standard. So what did the task group do? So the task group, like I said, they took these recommendations and they put them into a way that made sense in a regulatory standard. And basically that means they had to be worded in such a manner that the regulator would be able to figure out, has the physician followed the rule or not? So we couldn't say vague things like, consider this or do your best to do that. That's not going to cut it for a regulatory standard. It has to be very black and white so that if there's a complaint, then the regulator knows, did the physician do it or not? Are they going to be disciplined or not? So sometimes nuance is a little bit lost, but nevertheless, we were able to do that. And we were also able to produce a second document which gave some clinical flesh to those rules. So there was a rule, for example, the physician should make an attempt to involve a person's family members or loved ones or significant others in discussions about assisted dying. And then in the second document called Advice to the Profession, which is often a companion document that regulators will produce when they make standards, it gave more clinical detail about what that meant. In addition to these 4 repeated concerns about incurability and irreversibility, suicidality, capacity and suffering, we also gave instructions about interpreting the requirement that a person give serious consideration to the means available to relieve suffering, and on handling refusals of all kinds, refusals of treatment, refusals of collateral history, refusals of involving family. And that's, again, something that comes up a lot in the public conversation. Okay, so what I want to do just is to really get into the details of what was said and kind of in which documents you will find this information. So the task group gave guidance on irremediability, and the asterisk is there to tell you that the CPSS took the task group's wording on this point and integrated it into its own standard. So the task group, through the model practice standard and advice to the profession documents, said that the incurability of a condition has to be established in reference to the severity of the condition, to the duration of the condition. There need to be no remaining recognized, available, and potentially effective treatments. That has to be made in reference to the person's overall state of health, and of course, taking into consideration their beliefs, values, and goals of care. So you will find this in the CPSS standard if you look. That was on incurability. With respect to the irreversibility of decline, the model practice standard gave these 3 points. The CPSS retained only the first one, so that capability refers to a person's functioning, physical, social, occupational, or other important areas, not the symptoms of a condition. Function refers to the ability to undertake activities that are meaningful to the person. And then we gave some other recommendations of things that should be integrated with respect to what makes a decline an irreversible and advanced decline, but those were not taken up by the CPSS. I haven't done a review of this, but it might be that other colleges have put those in. On suicidality, the model practice standard recommends that assessors and providers must take steps to ensure the person's request for aid is consistent with their values and beliefs, unambiguous, enduring, rationally considered during a period of stability, not during a period of crisis, and may require confirmation in serial assessments. And actually, the CPSS, in its wisdom, did not create a separate section in its standard called suicidality, the way the model practice standard did, but actually embedded this in the general obligations of all MAID assessors. And I think that is actually a very powerful statement about recognizing we can call it suicidality if we want, or the impulsivity that can occur across MAID requests and is not specific to mental illness. With respect to capacity, the standard says that capacity is fluid and may change over time. We said all the regular things that were already in there, by the way. We didn't ignore, understanding and appreciation and all that. I just put on the slide to make it less busy the things that were add-ons in order to respond to the worries that clinicians were expressing with respect to capacity. So capacity is fluid, it may change over time. Physicians and nurse practitioners must be alert to potential changes in capacity and, where appropriate, undertake serial assessments of capacity, and where appropriate, consult with clinicians with expertise in the assessment of capacity. So the CPSS retained the first 2 points, and they actually went a step further, and for the second point specifically named psychiatrists and psychologists as the people who could be consulted about decision-making capacity. The last point may seem sort of motherhood and apple pie, but it's there for a reason, which is to say, walking into a room and getting an impression that the person is capable is not good enough. It must fulfill clinical and legal standards. So that means you need to go through the criteria and you need to document that the person fulfills those criteria for capacity. I know in Quebec, in the early days, we have a formal oversight commission in Quebec. Plenty of the declarations were being sent back because people were writing things like next to the capacity box, like MOCA 26, right? Or seemed well, things like that for capacity assessments. We're like, no, that doesn't cut it, right? You need to do capacity assessments properly. So the task group on suffering. So Lillian's already mentioned this, but I think it is worth mentioning again that one of in a way, the model standard doesn't need to say this because the law already says it, but it's good to reinforce it in the standard, which is that a person's suffering must be caused by either their serious and incurable illness, disease, and disability, or their advanced state of declining capabilities, or both. So, the purpose of putting C here in this list is to really nail home that the person who says, I want MAID because my wife won't take me back, that's not a nice situation for you, but that is not, suffering by itself is not enough. It has to be this particular kind of suffering. And we can have an interesting conversation about why in our society we considered medically related suffering to be much more important or severe or worth responding to than other kinds of suffering, but that's a separate conversation that's not relevant to the MAID law. And again, the CPSS has integrated all of this language into the model standard with respect to the assessment of suffering. So we have to look at all of the dimensions of a person's suffering, the consistency of the person's assessment of suffering, their overall clinical presentation, and express wishes over time and life narrative need to be explored. And the practitioner must be of the opinion that the suffering is enduring and it is nevertheless subjectively experienced. So, have I skipped one by mistake? No. Okay, serious consideration. The CPSS didn't care about this one. There's nothing in there. We thought it was important, though, and I'll tell you why. Particularly in a psychiatric context, we thought this was important. So one of the things that clinicians will often say is, people can seem like they have capacity, but, and what follows the but? It's often something about they understand and appreciate, but there's something about their reasoning process that is distorted in a global way. Such, for example, somebody who thinks they're a terrible person. The world would have been better off without them. Maybe they can understand and appreciate the risks and benefits of an antidepressant or the risks and benefits of having MAID, but their overall worldview is distorted in such a way that they cannot really see themselves being able to be better in the future and making a positive contribution in the world. So the idea of that the task group said, look, a person already has to have capacity in order to be eligible for MAID. But there's this other procedural safeguard, which is the assessor and provider need to make sure the person has given serious consideration to the means available. Well, what does that mean? And as a psychiatrist, right away comes to mind the person who comes to you, they don't want anything, they're completely shut down, you can't even engage them in a conversation, it's all, no, I'm doing this, give me that, or don't give me that, whatever it is. So that's what this section was really meant to capture, that capacity is not enough. The person needs to give serious consideration. It has to be careful thought. It has to not be impulsive. And the idea was to really weed out those people who are completely shut down and who are not sincerely open, actually, to hearing what kinds of options, very much the opposite, actually, of Bob, who was open in the end to hearing, and then the serious consideration test turned out to be quite useful in that case. Okay, so now refusals, and this came up earlier in our questions. So the task group considered refusals, that all of the refusals that seemed to be clinically relevant: refusals of treatment, refusals to obtain collateral, refusals to give access to past medical records, and refusals to participate in additional consultations. That's actually something that's coming up a lot now. Track 2 patients who the assessors want them to see psychiatry and the patient won't. And so what do they do at that point? So with respect to treatment, what we said is that the incurability of an illness, disease, or disability does not require that a person has attempted every potential option for intervention, irrespective of potential harms, nor that a person must attempt interventions that exist somewhere in the world but are inaccessible to them. And this didn't seem to us in any way strange. It sort of seems to be what we do in practice all the time. At the same time, a capable person cannot refuse all or most interventions and automatically render themselves incurable for the purposes of accessing MAID. So this little piece actually comes from the advice to the profession document, right? Because obviously you can see this is not written in such a way that the regulator would have any idea what to do with it if a complaint was made about you. But I was trying to give additional clinical guidance with respect to assessing incurability and how to handle that situation of the person who refuses treatment. And the concept that we were really pointing to in this paragraph is this concept of the balance between realistic benefit and burden, which again is not foreign to what we do in practice all the time in all the non-MAID contexts. And just to point that this concept really came from the guidelines that have been developed by the Dutch Psychiatric Association, which I think are now in their 4th or 5th iteration, really getting at this idea that no, you're not going to say to somebody you must have tried everything that exists in our region or province, but you're also not going to give euthanasia in their case to somebody who hasn't done anything. There's a middle ground somewhere. Here are some concepts to help you get to that middle ground with your patient. As Lillian's already said, refusals about collateral, about sharing information, and about seeing other consultants, we recommended that they be handled exactly as she described, that if this is information that in good faith is required to do your assessment, then you just can't complete your assessment. The person needs to be informed of that, and at that point it's up to them. Okay, so now psychiatrist involvement. So the expert panel recommended that, and again, if you remember the expert panel's dilemma, which was that we were asked to give recommendations about mental illness as a sole condition, but we were sort of saying, we don't think these recommendations only apply to people with mental illness as a sole condition. We think they apply in lots of different kinds of complex cases, but we were not invited to give recommendations about all of Track 2 or all about MAID, so we had to formulate them as though they were recommendations about people with mental illnesses, but we always tried to make the language general afterwards. So we did recommend a psychiatrist be an assessor, one of the 2 assessors be a psychiatrist for requests of MISUMC, but if it was a different kind of case that was equally complex, that a specialist in that discipline be the assessor. So we were trying to sort of say, well, if mental disorders require a specialist, then surely other complex conditions require specialists as well. And this is exactly what the task group sent out to regulators. It put that in the first version of the model standard and sent it out to them. And to our surprise, they came back and said, we don't like this language. We think that you need to change it. The Criminal Code of Canada says that the assessors need to have a consultation with a person with expertise. We think you're going too far here. Now, I don't really know what their reasoning is, and I'm not saying this to be mischievous, but I do think we should ask Mr. Salt this question this afternoon, because I think it will give us insights into, I think, what seems strange to us outside of the regulator's shoes of why they don't just all get together and write the same standard. But there's obviously some reasons why they do what they do, why they didn't want this language, for example. And in fact, almost all of them agreed that they didn't want this language from all the different provinces and territories. So you know, the group was stuck a bit. Like, what do we do with this? This is what was recommended, and it was obviously something that some clinicians were asking for, but it also was not going to pass. It was clear that if we put that in the next version, they were not going to accept it. And remember, the ultimate goal was to try to create something that would be accepted so that the regulators would adopt it and that we would end up having a more harmonized system. So the group, and I remember conversations in our meetings and frantically texting and by phone, standing back and saying, okay, why is that recommendation there? What is it that we are trying to achieve by saying this specialist needs to be an assessor? What we're trying to achieve is two things. One, that assessors and providers get the help they need, right? Like, this is clerkship second week. If you don't know something, go and ask somebody who knows before you do something. So that's one guiding principle. And the second guiding principle is that people who don't know what they're doing shouldn't be doing it. Clerkship week 1. So, right? And this is kind of what I meant at the beginning, right? We have a whole web of knowledge and guidance and principles that already structure our practice and move us towards good practice. So we need to draw on those. And we said, well, what are people doing now? Like, how do they know? It's not in the law. It's not in the standard. How do they know when to get specialists involved and who to get involved and in what circumstances? And then we remembered, actually, regulators all have standards on scope of practice, right? What prevents me from prescribing antiarrhythmics? That's not in my scope of practice. And actually, more to the point, I'm a psychiatrist. What prevents me from delivering ECT? I mean, in principle, that's in my scope of practice, right? But the truth is, I don't have training in ECT. I've not been mentored in ECT. So clearly, I shouldn't be doing ECT. And I know that. And where do these principles come from? They come from the concept of scope of practice and from our positive obligation to respect our scope of practice. So what we did is that we used existing regulatory standards to enhance the MAID standard. And we said, assessors and providers must only provide opinions on MAID eligibility that are within their scope of practice. And further, that the person with expertise must ensure they have the expertise necessary to provide the consultation. In doing so, they must work within their scope of practice. And so in mental disorder cases, actually, the relevant expertise might be addictions, it might be geriatrics, it might be neurology. In fact, it might not be a psychiatrist. So even though this was not originally what the expert panel had in mind, in a sense, this returns to clinicians the responsibility to say, what do I actually need to know here? And who is the right person to ask, rather than saying, get this kind of a person and your job is done. So I want to speak quickly about additional mechanisms, some of which exist, some of which don't, which support good practice. And as I said, these are mechanisms that at any time we can start putting into place if we think that this is something that is relevant to the subgroup of MAID requesters who have MISUMC. So within provincial jurisdiction, there are retrospective oversight mechanisms, formal mechanisms. So in Quebec, we have the Commission Soins Fin de Vie, and they are responsible for reviewing every declaration of every MAID death. In Ontario, the same process occurs through the Office of the Chief Coroner. You have mechanisms that fall within, lots of different bodies could claim them, but they are typically in the rest of medical practice assumed by professional associations, so providing education, and CAMAP, the Canadian Association of MAID Assessors and Providers, has done that, but they're not the only group in the country that has produced educational modules, so other groups are free to do that. Clinical guidance and guidelines are also something that are developed by professional associations, and again, CAMAP has stepped up and developed these, and a range of complex case discussion fora. So CAMAP has a forum that's Canadian. In Quebec, we have a forum that's very similar to CAMAP's, but it's just for assessors and providers in Quebec, and I think Laurie's going to tell us a little bit more about initiatives in that regard with respect to Saskatchewan. And then, of course, there are plenty of local, regional, or provincial mechanisms that can be put in place, and some that have been talked about in the Canadian context. In Quebec, we've talked about the idea of multidisciplinary assessments. So even though it's a physician and nurse practitioner that have to make the final decision on eligibility, that doesn't mean that other professionals can't be involved in the assessment process, and we can decide how we want to make that happen at our place. When I am an assessor, or even when I do my consultations, usually one of the social workers in our team will join us, so we've sort of formalized it that way. I've heard talk, I thought this was a really interesting idea that has legs, of treatment resistance clinics. So the idea that somebody who is thinking about MAID would attend such a clinic. I'm not quite sure exactly the logistics of how you would assemble all the necessary expertise, but I still think it's an interesting idea that they would attend this clinic and really have consultations with the people who would have an exhaustive knowledge of treatment options and be able to go through that with the person. And then, of course, again, at local, regional, and provincial levels, complex case discussion mechanisms can be drawn upon to help assessors and providers. We have one in our own hospital as well, in addition to the forum. So I don't think these things are redundant, right? Because sometimes you have a case that's just relevant to your hospital group, and then other times it's nice to be able to reach out to a larger community. So the last thing I want to do in my talk this morning is share with you a few case vignettes. So obviously these are based on real cases. They've been appropriately fictionalized, but obviously they're not MDS-UMC cases because that's not allowed. What I want to do in showing you these cases is, one, how the assessors and the consultants thought through the case. Two, how the eligibility criteria and safeguards within the law, but as well as the directives in the model practice standards, help or don't help in the reasoning about the cases. And then I guess I would sort of leave it to you to raise the question in your own minds, and that we could pursue in the discussion about how the reasoning would be different, if at all, if we remove the physical condition from the case presentation. Okay, so in this case, I was the second assessor. This was a 32-year-old man requesting MAID for severe fibromyalgia and a history of severe major depressive disorder. And he had been documented as having multiple medication trials and combinations of medications, at least 2 different psychotherapies of appropriate duration and intensity, ECT, TMS, and ketamine. So this, I think, is the case for me, that illustrated why there's actually value in telling assessors and providers, get the help you need, rather than get this kind of help. So I'm a psychiatrist, but I didn't at all feel within my depth to decide myself, has he had adequate treatment for his psychiatric condition. I really felt I needed help from somebody with expertise in mood disorders. There's no law or standard that told me to do that. I think it's, again, the structure of how we practice medicine that said, you don't know something, go and ask somebody who knows the answer, or who at least is more likely to know the answer than you. So I had a case discussion in my eligibility assessment, both with the pain physician and with the treating psychiatrist who had that expertise. And I sort of basically listened to them, how they reasoned about the cases and what they factored into their decision-making about the irremediability, in this case, all 3 elements: incurability, irreversibility, and unrelievability. They talked about what's in their treatment guidelines. They talked about his treatment history in light of the duration, intensity, and skill of the provider. They talked about the possibility of off-label and experimental treatments, and they also re-questioned diagnosis. I put where appropriate for other cases, but they re-questioned the diagnosis in both cases. So that was very informative, actually, to sort of listen to 2 people work through clinically what their considerations were with respect to his treatment adequacy, which then helped me make my judgment about irremediability. So that's that case, and I think I also want to simply add that what I think we don't want clinicians to do is have a checkbox mentality. Oh, I got a psychiatrist, so I did what was necessary, that's fine, let's move on to the next person. I think what we want is people to think about, what do I need to do the best work I can do in this case? So here's a case of suicidality. All my case vignettes are about the four big issues, by the way. This was a 58-year-old man with severe pain secondary to chronic pancreatitis, non-alcohol related chronic pancreatitis, a recent lethal but failed suicide attempt, and he requested MAID. So I was told about this case rather than directly involved, but again, had the opportunity to listen to the reasoning of the assessors, and what they took into consideration was his persistent and unambiguous wish to die, and that it was rationally considered. And so that's very nice that they did that when they were considering his case, and I would say that the model practice standard actually significantly pushed the bar higher on how to consider suicidality by talking about the request being consistent with a person's values and beliefs, being unambiguous, enduring, rationally considered not during a period of crisis, and may require confirmation in multiple visits. So I think the standard actually is asking a fair bit of assessors and providers, and appropriately so. This was a case of questionable capacity, an 82-year-old woman with major neurocognitive disorder, associated Alzheimer's dementia about stage 5, as well as a history of major depressive disorder, but who was treated but lost to follow-up during the pandemic. And so here we know that capacity is an eligibility criterion, so she has to be capable in order to have access, taking into consideration the usual elements of understanding, appreciation, reasoning, and being able to evidence a choice. But she also had to give serious consideration of the means available, the Track 2 safeguard, and the model practice standard requires assessors and providers to get collateral history with the consent of the individual. And that actually was extremely helpful. I was the second assessor in this case because I could talk to her sister, I could talk to her friend, and it turns out there was a non-medical psychotherapist that she had been seeing over years who knew her very well. So getting that collateral history was really helpful in terms of having an overall picture of her capacity, particularly the enduring and unambiguous wish to die. So I have two cases that I want to show you about suffering for two different reasons. So this was my patient, actually. I wasn't involved as an assessor or a consultant. A 26-year-old woman, difficult to treat Crohn's disease, so that was well documented, and her gastroenterologist said, we're into third-line treatments now, with frequent symptom recurrence nevertheless, but who had also had a serious history of childhood abuse and neglect, and diagnosis borderline personality versus complex PTSD, and had had minimal psychiatric treatment. But the request was for Crohn's, okay? It's not about her psychiatric history. And I do think, and I think Lillian alluded to this is the kind of case that worries us, right? The sort of relatively young person. They may have a severe condition, but the horizon of time is so long ahead that, even though rationally we may not have something we can point to, do this and it will make you better, we think that more time needs to pass. And this person was refused. And I do think, people will often say, as we were discussing earlier, what about the young person who walks into the emergency room, the 20-year-old who has depressive and anxiety symptoms and says, I want MAID? Well, beyond the practical aspect, which is nobody's going to talk to them about MAID in the emergency room since it's not an emergency service, I think Lillian's point is very well taken. Go back to the criteria. Go back to the processes. It turns out this person is not in an advanced state of irreversible decline in their capabilities. Neither is the 20-year-old who comes to the emergency room with depressive or anxiety symptoms. So a compassionate and careful response to the request is still required, but I think the law and the standards and the processes that we develop will help us as well. And this is my last case vignette, and also a suffering case, and I was the consultant in this case. So this was a 77-year-old woman with lung cancer, was requesting MAID, her prognosis of less than 2 years with chemotherapy if she had it. She also turned out she had a long history of marital conflict, and the spouse had recently died, but she had nursed him to his death, so it was very fraught. She had a serious alcohol use disorder since her 30s and problem gambling, worse since the death of her husband, and apparently had spent the money that he had left her on his death in a relatively short period of time. So, of course, in this case, again, what's helpful are the eligibility criteria and the model practice standard, both of which state that the suffering must be caused by either the serious and incurable illness, disease, and disability, or the advanced state of irreversible decline in capability. It was really notable that in the psychiatric assessment, she did not talk about lung cancer at all. Actually, all of her suffering was clearly related to having gone through all her money. She even came back to me at some point and said, if you write me a letter, I can get such and such money out of the bank. So, I mean, it was all about these psychosocial circumstances. That was clear, and she wasn't eligible. But I wanted to show you this case also because I think this is the perfect case to illustrate that if we get hung up on diagnosis, we can easily forget all of the worries that pop up across the MAID spectrum and how we need processes and structures, not for people with specific diagnoses, but for people where these problems might be relevant. It turns out, I am sorry to acknowledge, that the first assessor spent 15 minutes with her and told her she was eligible, because I think as clinicians, we see lung cancer, poor prognosis, and we think, oh, that's fine, MAID, no problem. But I think actually, if the mental illness debate has helped us as MAID clinicians, it surfaced these concerns and made us think about them across the MAID spectrum, and hopefully also opened our minds to the possibility that some people, a small number with mental illness as their sole condition, may look very much like some of the people who are accessing MAID now in terms of the severity and treatment refractoriness of their conditions. So in conclusion, MAID requests can be complicated to assess. This is not exclusive to MIS-UMC, or actually even to track 2, that last patient was track 1. MIS-UMC requests require the same clinical reasoning that we are using in other types of analogous requests. As consultants, psychiatrists are doing the same tasks that we do in regular practice. We're assessing treatment adequacy, suicidality, capacity, and the suffering associated with the person's condition. And as assessors, I think the skills that we bring to the table, such as taking detailed personal histories, case formulation, understanding relational dynamics between patients and healthcare professionals and teams, can make a valuable contribution to advancing MAID assessment practices. Thanks very much for your attention.
Thanks so much for the talk, Dr. Gupta. I think you've left everyone kind of stunned. No questions. I have one though, and it's more about just a comment on the concept of like undue influence, like on both sides of that fence, and where how that might kind of practically manifest itself in clinical practice. Like, we talked about like being aware of your transference before, seeing a patient. Like, how much do we hold that before, being involved in MAID assessments or discussing MAID with patients on before we start? The concept of undue influence.
I just want to make sure that I understand. So you're making a link between undue influence and countertransference? I didn't quite follow that bit.
Sorry, I meant that because, in terms of assessing patients who might be requesting MAID, where we might kind of manage that part of, there's conscious objection, there's people who promote MAID, there's people who are more, let's say, against the idea of MAID, and how do we manage that in clinical practice when we're seeing patients, and like if there's undue influence when we're assessing people, because I think we're trying to standardize it as much as possible, but from case to case, there's always going to be that, depending on who's assessing that person and how do we manage that.
So you're talking about undue influence
Yes.
coming from the assessor
Yes,
themselves?
that's right.
Yeah, I mean, I think, right, like the fantasy is that there's some neutral third observer who is going to be there for every assessment, who is going to make sure that nobody is saying anything in a leading way or in a negative way that biases things. But I mean, that's not going to happen, right? So, I think probably the only things there are to do, and this is again where I think psychiatry has so much to contribute to MAID assessment practices, is to develop the capacity to be self-reflective, to put in place mechanisms, whether they're case discussions, whether they're opportunities for assessors and providers to talk amongst themselves, kind of as we do as psychiatrists, to say, like, I can't see that patient, this is why, she makes me mad, she reminds me of my dad, whatever it is, can somebody else see them? To be able to have the capacity to reflect in that way, I think is something that we want to be able to develop amongst requesters. Obviously, in larger jurisdictions, if there's enough people involved, that case swapping is easier. It might be harder in smaller places. But I think, I don't think there's a magic solution, but I think we're already doing that. So I think it's a question of transferring that skill to the MAID context. Okay.
Right, so if you have no other questions, then we can convene this, end this talk a bit earlier, and then move on towards our next presentation, maybe about like a 5-minute break, and then give me a chance to introduce Lori as well. Thanks again, Dr. Gupta. We can turn them on, yeah. Are those mics on? Okay. Hello, everyone, and those who are outside. I'd like to get started on the next portion of our academic day, which is a group presentation, but also like to introduce another speaker today, which is Lori Brad-Richards. And she's the provincial MAID program manager, and she's a registered nurse, and she's been growing in the field of nursing since 1987, and her career has taken her to work experiences in urban and rural locations within Alberta and Saskatchewan, and even to Texas. And she has worked and taught in areas of the emergency department, cardiac care, but also spent time with the Community Oncology Program Saskatchewan, or COPS, later becoming the outpatient site manager at the Saskatoon Cancer Centre. She's done project work including development of the Collaborative Emergency Centre for Cudworth and Waka, and established the Meditech order entry system in the former Lakeland Health Region of Alberta. And in September 2022, she became the manager of the provincial MAID program here, and has grown the team within Regina, Saskatoon, and most recently in Prince Albert. She also sits on the Federal Quality Improvement and Data Working Group and involved with studies on MAID in Canada. And her experiences with process mapping and diverse work history have allowed her not only to lead her team to navigate the delivery of MAID in Saskatchewan, but also look for opportunities to assist patients through connected care. So please welcome Lori Brad-Richards. Thank you.
Thank you. So thank you for this opportunity to present on this topic. I think from some of the questions that I've heard come across, I think it's important to give you a little bit of a foundational knowledge of what MAID is in Saskatchewan and how does someone access it. So my hope is to leave you with a better knowledge and confidence in the role that the program has for the patients who engage with us in either for MAID or with a sole underlying medical condition. So I would also like to, because we're part of the SHA, I would typically not combine these two slides, but I didn't also want to omit them either. I know everyone has likely seen these slides, but I wanted to make these acknowledgements as they heavily guide the practices of the provincial MAID program. We are firmly etched within the vision, mission, values, and philosophy of care for the SHA, and can easily apply many of these values with the reality of the patient health situation when it takes them to the point of considering MAID as an option. We acknowledge and honor the relationships with Indigenous people, recognizing the history is important to our future and our efforts to close the gap in health outcomes between Indigenous and non-Indigenous peoples, and the program respectfully works to incorporate traditional and cultural beliefs in our interactions with Indigenous people as it applies to death and dying. We recognize there are many underserved areas of care, especially in rural and integrated north. We cannot fix that, but we can work to ensure that there is access to the end-of-life options for those who wish. So who are we? The provincial MAID program, the core team is based out of Regina, Saskatoon, and Prince Albert, and it's composed of 3 nurse practitioners, 2 registered nurses, 2 registered social workers, a manager, and a medical director. We utilize a hub-and-spoke model to improve access and reduce wait times for patients by having approximately 52 affiliated assessor providers to the program. They are roughly represented by the stars on the map. We also have established a network with palliative care and primary health care staff who we may utilize to be that second person at the time of provision to assist the local practitioners in that area. Most of these assessors and providers do have a full-time practice and do MAID assessments and provisions in addition to those regular duties. Every individual who requests MAID comes through our program. No physician or nurse practitioner can give MAID without involvement from our program, and the process includes assigning an SHA agreement, obtaining expanded scope of practice, from the college, and then taking all of those documents to their local practitioner staff of affairs to apply for privileges. So the program does assist with that. And so if you or anybody you know is interested in becoming an assessor provider, you can contact the program and we'll walk you through that process. So what does the program do? The MAID program is a federally regulated, provincially delivered care service who works with patients who wish to explore medical assistance in dying as an end-of-life option. Under the umbrella of the SHA as its main access point for anything and everything to do with MAID in Saskatchewan. While a family member care service may contact the program MAID or provincial MAID program on behalf of a patient, nothing proceeds until we have explicit request from that patient to continue on with the process. We establish this through an intake and several federally regulated questions, but also with the time and conversations to help give context to their request. Capacity issues may present here, but as with most intakes are done over virtually, it can be hard to determine. Intake also includes obtaining a release of their medical information, and as Dr. Thorpe and Dr. Gupta had alluded to, we can't really proceed until we have that. And if the patient doesn't want to disclose their medical circumstances, we really can't proceed. With that medical information disclosure, it is at that time that we often discover some of the complexities of their request. As intake is done primarily by the registered nurses who are unable to diagnose, it isn't until the medical is fully received and at times flagged to one of our nurse practitioners to review that we have a clear idea of how quickly we must triage the request to assessors versus pausing to ensure we have all the medical and clinical notes required to help that assessor do their due diligence. When we have a level of complexity to the patient's request, such as a lack of supporting document of their medical condition, if there's an underlying mental health issue attached to their medical condition, if there are medical concerns that may pose difficulty in assessing one stream or the other, or there are psychosocial considerations or barriers to typical MAID requests, we add that to what we call a complex case interdisciplinary round, where we have all members of our provincial care team join, and then we try to make the best decision about how we will proceed. Sorry, I should get back onto this other page. Most of the work we see is pretty straightforward. We have a foreseeable death, they're pretty straightforward. And from there, we arrange for an assessor from that home community and forward to them the forms that they require, along with a copy of our intake and medical. When a patient has met all the federally required requirements and safeguards and are deemed eligible, we further assist in provision planning, which may mean connecting to our social worker for early on or for quick turnarounds, or if there's if there's young children, if the person is requesting MAID and is found eligible but they have young children at home, if there is some level of secrecy to their MAID request, they don't want any of their family to find out until after they've had MAID, we usually flag those to our social worker, and they try to help navigate the situation. And of course, our program, we attend provisions. So gathering up-to-date medical information is probably our biggest obstacle in providing a smooth transition to the assessors. It's not uncommon for patients who especially have an underlying mental health condition to have changing practitioners multiple times. So we are constantly changing the most accurate medical information that we can, and it's really made difficult because of the lack of a consistent electronic health record across Saskatchewan. When you call our program, you most often get an answering machine, as we are often on the phone. But we have a message directory which advises that MAID cannot be given to those with only a mental health concern, because prior to that we had multiple people that were phoning us to get on our list. Now I think there's an understanding that if you only have a mental disorder, then we can't do anything with you. We have, since about mid-2023, been collecting provincial stats on the types of patients that are coming to us with different types of mental health concerns, so that we can make better decisions moving forward, and I have some of those stats in slides coming up. So what happens when sorry, I was just going to say. So current state right now is we gather our clinical notes and we try to get it from the most responsible psychiatrist, which is difficult. Our future state is that we will have what we call an MD Sumac and complex case rounds, where we hope to secure a group of psychiatrists to provide consult to our team and our assessors about how to present. And that has just been in the very early stages of planning. So this would be our terms of reference at this point. So basically it's identifying that our program cannot make these determinations without the assistance of experts in their field. And it's really acknowledging that it's not just the mental health issue that can make them complex, and I think Dr. Gupta and Dr. Thorpe gave some really good patient examples of how that challenge is an everyday thing for us right now. We would hope that this panel will build on the work from our existing complex case round that we hold every month, but we also are very aware that to generate a panel of medical or psychiatric consultants that we wouldn't want you to feel like you had to attend without really acknowledging the level of your expertise, whether it's geriatric psych or if it's mood disorders and that sort of thing. So we see our membership as being all of these people, however, not needing to attend each and every time. So we're right now trying to formulate for the MD Sumac what would be the best way to help the assessors make the best decision for that patient, taking in all of the criteria that the two physicians have already spoken of to move forward with their request. So so I'm going to just say our data specialist has been sick for the last 3 weeks. So this request never got actualized, so this is my really weak attempt to try and pivot some stats. So we started collecting stats in 2023, kind of midway. And at that time, we were manually collecting them, and we were kind of collecting them at our intake where we asked, do you have, like your physicians, do you have a psychiatrist? And people would disclose, or we might find it in their medical history. And from that, we were trying to decide what areas of psychiatry do we see are more prevalent. So we do have, like as you can see on here, the chronic complex pain is a very highly utilized kind of patient population that we do see. We do have, again, this, and it's blank because it wasn't actually, it was listed as a chronic complex pain, but not specifically what type. We have a lot of geriatric psychiatry type issues. These are, we stratified our data capture in a better way moving forward. So in the 2024 quarter, these are stats on patients that we are already reporting to the federal government about people that had made, people who had a request but were found ineligible, those sorts of things. So we're kind of at a, we're not really sure how best to capture these. So we have patients who access our program who have a underlying mental health disorder or some other issue that's happening, and then they don't want to proceed. So we may not necessarily report that to the federal government, but we're trying to capture that provincially because it is workload to our program. So this is just for the patients, like just on intake, identified on intake of what we have. And we feel like we do have a lot more situations that aren't formally diagnosed. We have a lot of people with reactive depression that is not necessarily diagnosed just because they've been given the diagnosis of cancer and they're clinically diagnosed, but everybody's focused on their cancer and no one's really addressing that. We have patients who might phone to the MAID program and say, I want to die. And we'll say, like, what's going on? And so at that point, we're trying to decide, is there a level of suicidality just to their request? And then we would transfer their call to mental health workers that are affiliated with Healthline 811. If we've had, and it's not uncommon for us to have patients who phone and say, I don't really want to die, but I don't know how to live anymore. I'm going to lose my house. This is what's going to happen. And they're depressed and they're reaching out, but they just don't know what kind of community access they might have. So that is where we see our program in a kind of like a strategic planning type of way, is that we're connecting patients to community supports. We are connecting patients to physicians and other places, and we're actually connecting them to the pain clinic and that sort of thing. So we don't just see our role as just trying to get people who want MAID to have MAID. We're actually see ourselves as a bit of a gap fill within healthcare in Saskatchewan, where we hear what people are going through. We are going to call them back within 24 hours. They have a sympathetic ear, and we try to direct them where we can. And when we have no place to direct them to, or they are resistant to a solution, that's where we might have our social workers engage with a bit of counseling, and then transfer their care to someone else that can take it on. So I guess that's all I want to say about our program at this time, and I hope that helps explain kind of the process in Saskatchewan, because it's a bit unique, and we're only one of I think 2 in Canada that do have an official provincial program. Thank you.
So I'm just going to add a little bit to that. So the program initially, in Saskatchewan, we initially had a regional-based series of programs, each of which did their own thing, and that's still the case in lots of places across the country where there are regional differences throughout even a province. So we had that for the first few years until fall 2018, and so at that point, there wasn't that sort of centralized ability to get patients connected to other resources. So it would be all stuff we had to do ourselves. So, and that's the case for many people across the country. So when I go to national meetings related to MAID, there are lots of people across the country who don't have that resource. So if I see someone with lacking social resources, I'm able to just pop an email to the MAID program and somebody can follow that up. So since 2018, this has been quite different for us, and what we've been seeing this is increasingly necessary with track 2, because these are much more complicated. So the minority of track 2s I've assessed have gone on to actually do MAID, and that's largely because of connection to resources. So as Laurie, I think, was saying, that the MAID program is actually located within Health 811, and so there are a number of people in that program who have a number of areas of specialization and care. So it's actually it's a very useful way to put that program together, because they can quite quickly access resources that we as individuals may not always know that are available. So I think we're quite fortunate in Saskatchewan to have a provincialized program like this, and I see that as much more straightforward since the initial stages where we all had to do everything ourselves. So we had to scurry around finding some social supports, finding access to pain clinic and so on. Right now it's fairly straightforward. the complex case rounds are interesting, so really have them, and because the complexity isn't just limited to psychiatric illness, difficulties of psychosocial issues, what's missing with people, personality issues with people, so they're already happening. So we are just not making anything new. So Dr. Gupta talked about not reinventing the wheel. She didn't use that term, but having entirely new processes. I think that's the case in us, in that we would use an existing process which already exists for complex patients to then augment it with people from the appropriate specialty areas, and not just psychiatry, not just general psychiatry, but sometimes special areas within psychiatry, forensics and so on, or mood disorders, and maybe pain and so on, so as needed for each kind of assessment of complex patient. So what makes this doable is that, as I don't know if you saw, but they collect all the information. So, for example, I did a complex one. I've had a few contacts with a woman who came from Manitoba. And so how do you normally get those records? So if there was no MAID program, I would have to be scurrying around trying to find out who did they see, get consent for getting that information. Massive undertaking. So then I said, well, I need information from Manitoba. So they get it all, they put it all together into a series of PDFs. They're sometimes so long it doesn't fit in one, you can't email it, and they collect all that information. So I got information from Manitoba about all the care she had, the assessment she had, what happened with those, and had seen multiple people, and that was collected for me. So that would then all come to this complex case round, which is how I think this could be doable, and that we would have a number of these subspecialty psychiatrists that would be willing. There are a few already that have stated some interest in that, to provide consultation to that meeting as to what else is needed. So all the information is there, what's been done, what they've done with great effort that the staff have collected, and then subspecialists could then at this initial stage look at what do we need to do? What else do we need to try? What hasn't this patient tried? What is really missing in this whole story? So they would be subspecialist advice to this complex case round as to where we go from there. So that might mean somebody going on the list to see someone in particular, but it may not be a psychiatrist, might be a pain clinic and so on. So there are many complexities that could be discussed at that initial point, whereas we all know it's not possible to find an individual psychiatric assessment for every patient that caused the program, but at least we start out with that guidance from subspecialists in that area. So that's what many of us are thinking about in how this might work, and Mona might comment on the rest of the country, but I know at the meeting in Halifax we all had, this was a similar thing being discussed, that we would try to build on what's available in each of our provinces in the way that is sustainable and doable for us. We don't know some of the things we don't know yet. How are we going to pay those psychiatrists that are going to supply consultation services to that team? We don't know that yet. Maybe Laurie knows, but probably doesn't yet, and of course we haven't got there yet. But that would be one thing. How do we reimburse people? There may be ways we can do that. And so we're not there yet, but the plans are there. We initially thought this would happen, so we were pretty close to being able to make this happen, and then it was deferred. So we think we have a way that we could make this happen if it does happen. Now, what we've talked a bit about just privately is how difficult it is dealing with some people who are very much wanting to die. And currently people with personality disorders and so on who are very, very, very demanding, and how we deal with that. Right now, the MAID program staff, frontline staff, are dealing with that. This is something that we'll all be spending more time thinking about and how we deal about it. The advantage we have is that, as Laurie mentioned, that many of those cases might actually be quickly transferred, or at least obtain consultation from mental health services, which are also located within 811. And we're aware that this is going to be difficult. So there is that case I mentioned earlier that at least 4 of us have been reported to the college for turning someone down. I anticipate this will happen more, and we are happy to have ongoing liaison with the College of Physicians and Surgeons, and so we're happy Brian Salty is coming, because they will be aware of that as a challenge for some of us. And so the college has been very appropriate in dealing with that. Mona had already shown you that they've taken on most of the guidelines from our practice panel, which is wonderful, because those are our responsibilities as physicians. And it's great that they're right up front there. They've got great staff on capacity assessment as well. So the college has done a very good job for us so far. And we will stay in touch with them and work with them over all of these processes, because they have a lot to add to us, and they currently help assess people's scope of practice and so on. But they've done more than that for us. So just expressing, so we are in a position that I think is a little bit easier for us in Saskatchewan than other provinces that don't have a provincialized system. Manitoba's provincialized. Ontario has many regions. Larger provinces are more regional based. And then, and I don't know, probably Quebec as well, but smaller provinces, Manitoba, Saskatchewan, there's some advantages to having a very well organized provincialized system. I feel also it's safer because we can more easily review what's happening, that we have one body through which everything flows. Everything has to go through that program. And so I think it's easier for us going to be to make sure that appropriate standards are followed, and there's a better opportunity to do really oversight of what's happening. So yeah, we're all going to look for how we're going to do this well. Mona might know some more. Is going to talk a little bit after this about what her understanding is about other areas, but that's kind of where we're looking at. And if people are interested from a psychiatric point of view, there are a few that have already stated some interest that might add some consultative work to this complex capacity meeting when it happens. Perhaps they could get in touch with Laurie as well, and easy to reach Laurie. I think you might have had your number up before. I didn't have it up, but I could. Yeah, so we'll make sure her contacts are there, but we are interested in knowing, some of you, if you're interested, resident might be interested. I'm interested in looking at setting up some research, looking at what's happening to people, why they're happening, what are the unmet needs of people with mental disorders. So there may be a resident who's interested in a research project along that. We've done quite a few research projects with my database, where I save everything that I do related to MAID, and we've had a lot of summer projects on that. I'm interested in then developing that further when we get MAID for Soul mental disorders, which is a better term than illness. I'm interested in doing that and partnering with a MAID program in that, and perhaps there's some residents who are interested in looking at following through on a forward basis what's happening with these patients. And maybe to start with even some of the ones that have obvious comorbid mental disorders, what's happening with them, what are the unmet needs, how can we best service those people who are obviously in difficult circumstances. So there's lots of possibility. The MAID program has a good data system, although right now I think somebody's been off for a while, but the data is all collected on a provincial basis. So it would be very doable to develop really good quality assurance projects for people with significant mental health comorbidities and eventually soul mental health. And I'm very interested in us doing that, because we want to look forward to the future. How do we do a better job? How do we stay appropriate, keep our patients who are often in very vulnerable situations getting good care and good outcomes in what they're doing. So very happy that Laurie was able to come today. She's really busy, and it was really nice to hear that very easy to find that connection for any of the patients that you have, that there is, you Google it, you can get in contact through the 811 number to get information and so on. So it's very useful. So I'm going to hand this now to Mona, who is based in Montreal and has been extensively involved in national processes. If you have a little bit of commentary on what the rest of the country is doing in regard of planning for MAID for Soul mental disorders.
Is this on? Yes. It listened to you. Actually, before I start, I was hoping you would say a bit about the oversight process in Saskatchewan.
So we have an oversight committee that is made up of the 3 regulatory bodies, the regulatory body for the physicians, the nurses, and pharmacy. There's members from clinical documentation. We have SHA legal representation. We have members of the ministry that sit on that board, and we have an ethicist along with executive leadership from SHA. So right now across the country, they're kind of looking at quality assurance and oversight broadly. And so within our program, what we're focusing on is, because it falls under quality improvement, we're looking at what is not only legislatively appropriate, but the access for the patient. Were they given, what's the journey of the patient to the point where they actually are requesting MAID and through the MAID process? So that is also being monitored. This committee meets twice a year only at this point, and I will say that COVID did a bit of a hit on them in terms of we had a whole complete change of membership, and there's still some people trying to get in the know of what MAID is. So there's a little bit of a work to be done there.
And do you look at the completed declarations, or you discuss every case, or select cases, or is it more kind of you pick an issue and you work on that? Yeah,
so we're just like, so I guess we'll back this whole thing up. So when a patient makes a request for MAID, they go through intake. There's some federally required questions that are asked and answered. Then it is sent to the assessors. Our forms that they use contain all of the federally required questions that must be answered, and then they send their forms back to us. They have to have answered yes to everything for someone to be considered eligible, but they also indicate at the bottom of the page whether they found them eligible, the date, and their signature. If there's any incompleteness or anything that doesn't seem quite right, we will send it back to the practitioner for clarification. We have to have 2 eligible assessments to deem somebody eligible. When the person is deemed eligible, we will contact the patient and say, like, when were you thinking about provision? The date is negotiated between the patient and the practitioner who's going to provide the care. And as Dr. Thorpe said, we're not a 24-hour service, so we can't just have someone say, oh, I want MAID in 3 hours and just mobilize that way. We're not set up that way. Before the forms that are required for the actual provision, which would include a prescription for the drugs that are required to be sent to the pharmacy, and the federal or the consent that the patient signs prior to provision, the program will not release those forms until we see all of the questions asked and answered and that the forms are meeting the regulatory requirements. So that is oversight even within our provincial program alone. Once those forms are then sent and the provision occurs, the forms are returned back, and once again, we are reviewing to make sure that all of federally required regulations and safeguards were asked and answered, and the forms were completed correctly. From there, we submit them to our data kind of clerks. They input into a data collection system, and then we have a data analyst that formulates a report to send to the federal government on a quarterly way. So.
Add one little thing to that with I think one of the important things that I particularly like is growth in how we onboard people doing this. And so this is something Laurie's been very involved with, which we didn't have before. So how we onboard people is how we make sure that the people are starting to do this actually do it the right way. And so this is all stuff that's being brought in. So there's a process so that people get to shadow. They have some reading material, then they shadow people for a while, then they're observed for a while for their first few assessments. So somebody goes with them. So these are all things that we're trying to make sure that our process rather than just scrutinizing it after the point, is actually starting at day one, even before people start, that we have a good onboarding practice. So this is gradually coming in. People who've done it for a long time have actually not had that, because it's such a new process. We're all developing what we were needed to do. So there are people who've been doing MAID for a while that haven't done that, but the newer ones that are coming in, this process is really growing, and it makes me feel much less worried about how things will work, because those of us who've been around for a while always worry about the vulnerability of our patients, and how are they going to be dealt with, and do people really know what's happening with them. So I'm very happy that we have an increasingly sort of well-developed onboarding system that is going to make sure people who do this are trained, and that has the ability to grow with what we know about MAID and what the changes in processes are and the laws are and so on. This onboarding is a really positive thing. So I'm really happy with that, rather than just have a review process after it's all done. It's good to start on ground one with the people who are doing this, to make sure that they are on board with what is appropriate for processes and so on.
Yeah, and just to add to that, I recently attended a presentation on behalf of the Ontario Coroner. So their oversight in Ontario is that all of the MAID cases are reviewed by the coroner, but they're done after the MAID has been given. So they released some of their data, and in some of their data they had said that there was cases where a consulting expert there was never a consult to an expert in the area of the person's greatest suffering. That would never happen in Saskatchewan, because when they return their forms, we're looking, that's a specific question. So if they say no to that, and it's indicated by the stream that they've chosen, we'll turn around and question them before the provision occurs.
So my task is to zoom out a little bit and talk about additional mechanisms, and I alluded to this during my presentation, that are happening across the country, and I'll take us across the ocean as well and tell you a little bit about mechanisms overseas. But I first just wanted to congratulate you on the robustness of the program that you've developed here, and there are certainly aspects such as the requirement for credentialing, the involvement of the program, the central involvement on kind of being on the shoulder of the assessors and providers in a constructive way that I think the rest of the country could definitely learn from. So it's really, really great to hear. So I'll just say I don't know a lot of details about these things, so I apologize if I'm short on substance. But I wanted to say before I start that I think we want to think about these additional mechanisms as contributing one of two things, or both. So they either contribute some new substance to the process, or they contribute some administrative framing of the process that helps it to unfold. And some of these mechanisms are more oriented towards the substance, and some more towards the administration and the organization of the program, both of which are important. So Nova Scotia, as I understand it, has a MAID program. It's not a centralized program like Saskatchewan and Manitoba in the sense that all cases run through them, but I think essentially it's a governance structure for MAID in Nova Scotia, and then you have subunits and individuals fanned out across the province. But I think what they've done to prepare for the subgroup MISUMC is create an MISUMC sub-program of that larger program, which has its own psychiatrist lead. And I think to respond specifically to the issue of funding, I think that their MAID program made a case to their Ministry of Health that this was needed, these were the resources needed, that was studied, negotiated, et cetera, and they were allocated resources for a psychiatrist lead as well as allied health support to do probably some of the work that your global program is doing for those specific cases. I want to tell you a bit about the Quebec system just because it's unique, not because anybody could possibly reproduce it, because it's all part of the complexity of our system, but it is very interesting, which is that when the Act respecting end-of-life care was passed, which, by the way, was before C-14, the ministry, not in the text of the law, but in their statements to healthcare institutions, required the creation of the GIS, which stands for Groupe Interdisciplinaire de Soutien. So it translates as interdisciplinary support group, but it doesn't actually make a lot of sense in English. In any case, it's a group that every hospital, every regional health authority has to have that offers clinical administrative support to MAID assessors and providers. So there are many JUSs across the province, I think more than 90, and they all are a little different. Some are very, very involved and hear about a lot of cases and are there to support assessors and providers when cases are complex. Some are a little bit more removed and help with administrative aspects, but they themselves have a community of practice and a forum and an annual conference. So they're a kind of structure that has been created and now has been codified the last time the Act Respecting End-of-Life Care was amended to exist throughout Quebec to provide this kind of clinical and administrative support to assessors and providers, including hearing about complex cases. The idea of the treatment resistance clinic, I believe, comes from your neighbors in Manitoba, from their centralized MAID program that thought that this would be a good way to essentially know that the people that were calling in and coming to them for assessment had already received psychiatric consultations as appropriate to their condition. So I don't know, and maybe you know better, whether that has continued its evolution or since the new delay was introduced, whether that they've stopped working on that. I mean, in some senses, that would be a great kind of clinic to have for lots of different conditions, because since most assessors and providers are family physicians and then another group are nurse practitioners, nobody has expertise in every disease out there. So these kinds of programs are probably great, particularly for rare conditions. British Columbia has a regional team system, but they coordinate amongst themselves. So even though they have regional teams and each team has its specificity, they also have a community of practice where they share and they work together in terms of developing administrative processes particularly. I want to say a little bit about mechanisms internationally. So I think what you're alluding to, Lori, is the distinction between prospective and retrospective oversight, and those terms may be familiar to you, but as you said, retrospective oversight, looking at what happened after a MAID death occurs, and prospective oversight is looking at what's going as the patient moves through the process before the death occurs. And I think it's really important to recognize that any retrospective oversight mechanism will inevitably be a paperwork exercise, right? The patient is dead, and you are looking at the declarations that have been submitted by the assessors and providers. In some cases, if you're not satisfied with them as the oversight body, you'll maybe calling for the medical record, but you're looking at what has been documented by the healthcare professionals involved. So you cannot know. That said, to a certain extent, even prospective oversight mechanisms end up being paperwork exercises, because there is no prospective oversight mechanism in the world where the committee members, for example, go and meet the patient and do an independent assessment of the person's eligibility. So in Colombia, for example, if a MAID request is made in hospital, the request goes to a hospital committee that reviews the paperwork. Now, of course, they can say, oh, we're not satisfied by your answer to was the person capable, please come and explain to us if the person was capable in more detail. And so they can provide that, not only quality control, but I think education, because I do think most healthcare professionals are well-intentioned, and when they make these kinds of errors, it's because they thought they were doing something right, and then they learn that they were doing something wrong, and then the next time they do it better. So I think, again, the fantasy is that prospective oversight will mean that there's some external party who will follow all of us around and make sure that we're all being neutral and respecting every rule, and I don't think that there is a way to make that happen for all MAID requests. That said, there is perhaps a role for something like an observation once a year or once every 2 years or something along those lines. I think it would remain to be seen whether ministries of health and regulators have an appetite to engage in that kind of surveillance. I also wanted to mention Spain, where there is a prospective oversight process, including that a member of the Prospective Oversight Commission has to attend the death. to ensure that it unfolds as it's supposed to, according to the processes. Let's see if they can maintain that once numbers increase. Spain is early in its regime. I think it's worth mentioning a couple of non-legislative prospective mechanisms. So Colombia and Spain, these are legislated prospective oversight mechanisms. In the Netherlands, you may have heard of what used to be called the End of Life Clinic. It's now called Euthanasia Expertise Center, I think, which will receive requests from people whose physicians are conscientious objectors or don't want to be involved for whatever reason, and they receive a fairly significant percentage of the MISUMC cases in that country. And what they will do, so this is a policy in one program, but it's, I think, informative. The people involved in the case will get together after they've done their assessments and have a case discussion. And that's part of the functioning of that program, that they need to do that. So that, again, I think offers a kind of oversight. In fact, it's probably the closest that you can get to the fantasy neutral third party who follows you around and checks on everything you do, in the sense that you have to explain to your colleagues who are not involved in the case, what did you do? And they're right there to sort of say, that doesn't make sense to me, or did you think of this, or maybe you should go back and do that. I think the beauty of the Saskatchewan setup is that you send them back and say, the explanation isn't good enough, take your form and go back and do it, and come back with it. So there's a little bit of control that way. And then the last jurisdiction I want to mention is Belgium, that has a mechanism. So this is not legislated, but comes from the regulators. Again, interesting, that polycentric model of regulation, that any patient who's not at the end of life has to be seen by 3 people. And after the assessments are done, the 3 have to get together and have a case discussion and come to a majority view about eligibility. So again, another interesting way to check what you've done, check in with your colleagues about what you've done, and see whether you're aligned or whether somehow you've kind of gone off the rails in your assessment. And these mechanisms all have an educational benefit, I think. One thing I don't know, and I don't know if there's any data on it, is whether in these places that have this prospective aspect, whether people's practices improve, for example. I don't know any data on that. I wanted to say one last thing about prospective oversight. So the expert panel actually this was one of the non-clinical recommendations, because at that time psychiatrists were asking for some kind of prospective mechanism that would help them in assessments of MISUMC cases. But again, I think the fantasy was not of the third party who would follow them everywhere, but of a third party who would make the decision for them. So they would submit, this is what I found, thus and so, what is the person eligible or not? And that kind of mechanism cannot be implemented in this country, because the decision about eligibility rests with the 2 assessors involved in the case. What any kind of committee mechanism can do is offer ideas, suggestions, opinions that will inform what the assessor and provider do. And I think if we want to formalize it, it might be interesting to say, well, if the committee recommended something and the assessor didn't do it, why didn't they do it? So for example, in the Netherlands and Belgium, you must get a consultation, but you don't have to listen to that person. But if you don't listen to that person, you better be ready to explain why you didn't. So, again, these are all interesting ideas, ways that we can continue to strengthen practice for MISUMC, for MAID, but honestly, I would love to have somebody submit my notes to somebody and say, am I doing the right thing with this patient? Please tell me how I can make this better. So these are things that I think can improve practice in general. I'll stop there.
Sorry, I might just add about just our basic complex case rounds right now. When we discuss the patient, the most responsible program team member will present the scenario and what the challenge is. And then we'll have a discussion and we make a plan for who should assess. And there, while we have 52 affiliated practitioners, we probably have only 35 that do it really regular, and 17 that probably feel comfortable enough to take on a track 2 or a non-foreseeable death type of request. There is a certain level of like, it's really difficult to try and navigate some of the patient's experiences. And during that complex case round, while we have a discussion about what's happening, do we need more medical, should we do simultaneous assessments, like independent simultaneous assessments, so that the assessors are hearing the same thing from the patient at the same moment, because we feel like that's some value to that. And then we might just say, you know what, the best person to assess this person is like Dr. Thorpe, or someone like who can really kind of, you know, flesh it out better than someone who has limited experience. So we try to make the best decision for the patient, but also legally to make sure that we're not just pushing someone through without making sure every one of those legislative requirements are truly addressed.
I really like the approach that we have, that our assessors can speak to each other. So there's been some chat on the listserv. There's a made listserv that to be independent, the assessors shouldn't even talk to each other. And we have felt that both assessors should have access to all the available information. And sometimes somebody collects information that the other person doesn't, but we should both have access. So it's not infrequent that one person has a different opinion from the other one, but once we chat, we realize that they got a source of information that was not available to us at the time. So we feel that it's important for us to have all available information to make the best decision. So even although technically we're independent, so that it can't be, say, a resident of ours and ourselves making the decision, or someone we are training or mentoring, it can't be that, but we can talk to each other and then brainstorm about what the best decision is, because I think more heads are better than one. And so I like that. And I know I've heard from people across the provinces that some people feel they can't talk to each other. I don't think that's good. And I'm glad we are. I don't know what Quebec is like, but we talk to each other. And oftentimes you can get consensus when you get the same information. As Laurie's saying, sometimes you need to see the same patient at the same time, because otherwise, sometimes different times of day, even you got different points of view, or somebody's better at eliciting some information than the other person. So we talk to each other, and when needed, we talk in a little group about a complex case, which is, I think, the way to go.
Yeah, in the sense of the Criminal Code of Canada, independence does not mean you can't talk to each other. It means you can't be in a supervising or power relationship with the person. And again, if you think about it, just to sort of second what you're saying, like in all of our clinical practice, when we don't know what we're doing, we sit down with somebody else who's involved or another healthcare professional and talk through the case. Mm-hmm. So why would we do something different here? I will say that clinically, there, like certainly in the beginning especially, if I knew the first assessor was somebody really experienced, then I get all nervous and think, oh my God, what if I think of something different? Then I purposely didn't want to look at what was in the chart, because I didn't want what they found to influence what I found and then be nervous about what I was going to say. But again, you sort of like use your clinical judgment and reasoning to help guide that. But yeah, independence does not mean that.
And I'll add to that too, like the value of going at the same time is that often patients will try to coerce the assessor into making them eligible. And so I feel, just for the protection of that assessor, it's important to have maybe someone else, if one's in person and one's listening in virtually or watching virtually, that there's value in that, because it can be very difficult to tell a person no and then leave. So yeah, that's the other point.
Do we have any questions? So people can ask us. We have a few minutes left before it's lunchtime at 12:15. Do we have any online questions? Oh, we see a nod.
Yes, we have one. So this is from a Saskatoon psychiatrist. She says, "Thank you so much to our presenters for such thoughtful and informative talks. My question is long and somewhat related to the one asked earlier by Dr. Ahmed. I wonder how our panelists envision reconciling the tension between timeliness of care, lack of psychiatrists, and ensuring practitioners with sufficient training are involved. Currently, wait lists for psychiatrists may be a year or more, and I think there are issues with any possible scenario. Scenario 1, MAID applicants wait 1 to 2 years for assessment. Scenario 2, MAID applicants are expected ahead or expedited ahead of other psychiatric patients. And scenario 3, nurse practitioners or other professionals who may not have the same expertise are assessors, and psychiatry is not involved.
So again, I think that's a concern many of us have, that we have to make sure that we get a proper qualified assessment, and that's why we're thinking about this model of the committee in which we get specialist feedback to material that's presented, collected. So great information is collected, and a subspecialist of that appropriate background that's appropriate could then give guidance to that committee, because we're aware that there are long waiting lists and that psychiatrists cannot be quickly found for every patient, nor should they jump the waiting list that other people are waiting for. So we totally agree with that. And so that would be one thing we have discussed in how we do that. Now, there are going to be cases where we really feel a person needs to have psychiatric care for some time before we can consider them, and those people will have to wait for that. And so they don't jump queues. At least that's my sense, and I think Laurie agrees that there are going to be people who need to engage in appropriate care before we feel comfortable with this. So we have one right now. I'm not sure if Laurie's aware of this one that is really got obviously significant mental health issues, comorbidities, and we really feel need to follow through and access mental health care. And until that's happened, we don't feel comfortable going ahead. So yes, we hear that concern, and that is a concern, and we are hoping we can find creative ways of doing a good job without having people queue jump. And because that's not going to get us anywhere, because then people are going to ask for MAID in order to queue jump, so it's not possible. But we also want to make sure we have appropriate assessments with a specialty of appropriateness involved in that decision making. So, Lawyer, do you want to add anything to that?
Yeah, there is absolutely no ability to queue jump by accessing MAID. We do not have any clout with the pain clinic. We have no clout with the GEM assessments, even though we have Dr. Thorpe in our care. But what I'll say is, if upon an assessment, the assessor feels that they cannot proceed with their evaluation any further until the patient has a psychiatric evaluation, the patient will be found ineligible. And then that would be the direction. If, say, the patient was awaiting a psychiatric evaluation, we do have a bit of leeway within that assessment to deem them pending. But with that, the assessor has to let us know what it's pending. So if it's pending some sort of an appointment in 4 weeks, so they haven't made a decision if they're eligible or ineligible, they'll indicate that the person is pending. And then when that time frame comes up, we'll question like what's happening. And if there's no movement, we'll just kind of try and see what's happening with the patient. But if it goes beyond 6 months, we say to if you can't make a decision about someone's eligibility within 6 months, then they're ineligible.
Yeah, I think what I wanted to say was kind of goes back to the theme of what I spoke about, which is, I don't know what it's like in Saskatchewan, but for sure in Quebec, psychiatry is not the only discipline that has wait lists. And so, again, in the spirit of not reinventing the wheel, I think we can look to what our colleagues are doing in other disciplines. And exactly, the pain clinic has wait times, the memory clinic has wait times, some of the subspecialized and rare disease programs have long wait times. So I think this is going to vary hugely how different programs choose to organize the trajectory for the MAID requesting patient who also needs some other service or wants some other service or is on a wait list for another service. But I think we probably need to, in psychiatry, turn to what's going on in the rest of medicine, because this is already happening, and I think programs are coming up with solutions in different ways. I guess the only other thing that I would add is that I worry a little bit about the discourse of queue jumping, in the sense that I don't think it's just patients with psychiatric conditions who might want to Q-jump. I think lots of people want to Q-jump because they're waiting for a long time with different kinds of conditions or for different kinds of service. And I don't think you build social policy worrying about the minority of people who are going to game the system. I think you got to build social policy to serve the people who sincerely want something, and then do whatever you need to do for the minority who game the system. But that wouldn't be my thinking that we need to construct the system because in order to deal with the people we think who are going to game the system.
I think I raised the Q jumping thing because patients with lived experience have raised it to me. So people in small interactive groups I've met with from Mental Health Association have raised that as a concern, that it shouldn't happen. So I think it's out there in the community. So whenever we have something out there, we respond to it. And we should have policies for that. Although we hope it's not going to be a major issue, but it's raised by enough people that I think we don't want to not discuss it, so that I think we do have policies. And yes, there are going to be people who are going to wait for some time for appropriate psychiatric care, and we're going to say we can't make a decision until you have. And we have been hearing that the people take sometimes a few years to get stabilized. So that's what it's going to take. That's what's going to take. And so people are going to wait to see the care that they need to get, and they have to go through that before we can sometimes consider them eligible in all areas, not just mental health. So we have them in other areas as well. So in Crohn's disease, it's interesting because I have one very similar young woman with Crohn's disease, and she really and agreed. She didn't argue with us. We felt we didn't feel comfortable until she went through some appropriate trials of treatment that were going to help her. And so that happens in all areas. So it may not be instant, and we may end up having to say that this needs to wait for some appropriate connection with services. But those concerns we know are there. Yes.
Hi, thank you again for such a great presentation. My question is about the treatment or access to treatments, specifically with regard to psychological treatments, because one of the sort of underlying principles, at least as I understand it, is the patient has to have tried a few different things. Like they had to have tried to have gotten better within reason. Now, when psychological intervention is indicated as the primary intervention that this patient needs, how do we address that when those patients can't pay for the psychological intervention themselves? Because that's not a public paid service, it's private paid, and that can be very challenging. Or if they do get the public stuff, which is minimal from what I understand in terms of accessibility, there's a wait list that's sometimes just as long as the wait list to see a psychiatrist. So how do we address those issues around treatment where the treatment that is required is something that the patient would actually have to pay out of pocket to get?
Yeah, so it's a great question. It's one we often think about. How do you deal with that? There are, I think some of these questions will come to a complex case panel where we're all going to brainstorm about how we can best meet the needs of that person who needs some sort of intervention. Well, in the short term, we see a lot of patients in our geriatric program as well that we have similar issues with, where they really have need for psychological support. There are a number of supports through the mental health programs, so that some social workers provide free services. There's some group services that are free within our health system. There is an online cognitive behavior group through the University of Regina, which a number of our patients have accessed, actually. So not everyone has access to the technology that involves, but some people do. So I think there's going to be good discussion about each case. What does the person need? And how are we going to proceed from that? There won't be one answer to that, but it is obviously an ongoing issue. Like how do we meet people's needs where those needs are hard to meet? And I don't think the answer is always to have a quick death by MAID for those cases when we don't have that. There's going to be lots of discussion and hair pulling and how we kind of think through these cases. And I think Laurie's going to probably comment on that as well.
Yeah, and we can't magically pull anything out of air that's not there to pull, but we have the best social workers that are interconnected to so many different programs, and they have access to look for funding. They have things to try and connect them to someone else who could help them. Like we're really trying to work with like connected care to help patients where we can. And unfortunately, for some patients, it's dire for them. So we try also, if we, like, going back to what I said before, if a person's deemed ineligible because they can't get into a psychiatrist within 6 months, we do connect them back to their family doctor and make them aware of what the situation, so that they're not just dangling out in the universe with nobody kind of watching them.
Yeah, I just wanted to come back to the payment issue. You know, again, I think there are lots of other conditions where the service that might assist the person. So I'm like thinking of one patient I saw with Ehlers-Danlos syndrome, and what she really needed was physiotherapy and then like exercise therapy in a sense, like regular gym attendance in order to maintain her muscle mass and mobility. So, I mean, like forget about MAID, right? So what do we do to help these folks? Well, we advocate and we do our best. And when people have means, we encourage them to access those programs. And I don't want to deny that this problem can exist, but my experience, and I'd be interested to hear yours, Lillian, is that the vast majority of people really want to get better, and they're going to do anything that they have to do to get better. So like, it's just not that common. Forget about the MAID context, that you have to convince somebody to try to do something to get better. That's what most people want. So I think it is going to be a problem that not everybody has what they need, but not everybody has what they need now, and not everybody had what they need before MAID. So we have to do the best that we can, and I think your program is very well structured to do that in order to try to get access. But at the end of the day, I completely agree with you. If you don't think the person has an incurable disease, an irreversible decline, or an unrelievable suffering because they are waiting for something, they're going to need to wait for that thing, and they're waiting for it anyway. So they're not eligible until then.
Dr. Thorpe, you kind of alluded to this a little bit, but I wondered if you could comment on remuneration for MAID assessments, because it sounds like there's quite a bit of chart review involved, and of course our fee codes don't cover that type of work. So like, is there contract funding, or kind of what's the situation? Thanks.
So right now there are a number of codes within the billing system. MCIB has a number of codes for MAID, and so they're not great, but there is remuneration for that. There is some remuneration for travel out of town, which has come from the MAID program itself. So they reimburse mileage when we're going to rural. So that was more common in the early days of MAID, where we were driving a long way because there weren't very many assessors providers. So that there's some remuneration. So in terms of chart review, it can be extremely intensive, but you know, my daughter's pediatric endocrinology, she does the same issue. So that to do a good complex subspecialty practice, there's a lot of review of charts. And I don't think MAID is any different in some of these subspecialties. That a lot of the work involved is actually chart review ahead of time, which you do the night before. You prep all your patients, and you read absolutely complex patients, which is why I think a lot of people don't want to see a lot of new consultations, because there's a lot of work to it. And it's similar to that for my complex geriatric patients. Like, there's massive chart review often. So complex patients are often not popular for people to see. That's absolutely true. So if I was struggling for income, I probably wouldn't do complex MAID assessments, because they do take a lot of time. So there's some discussion about having review again of some of the remuneration for MAID. It would be similar to all other areas where you have complex patients, and it's difficult. So I don't know, Lori, I know.
So our medical director, Dr. Michelle Jegas, she's out of Moose Jaw. She has been taking this forward and we've met with the ministry, and we meet with the ministry every 6 weeks to discuss our issues within MAID. They're kind of bouncing us between the medical services branch and the ministry to try and give us a firm answer. But outside of that, we've also spoken to the SHA to say that if the program is going to do what it needs to do, and we need to have consultants that we can realistically access, would the SHA be willing to provide some sort of remuneration for that? So those questions have all been thrown out there, but we all know it's in an election year and nobody really can stand firm on any one thing at this time. So it's been asked. It hasn't been full-on declined at this point.
Okay, we're at 25 past and our food is coming. So, do we have maybe one last question? Mansfield.
This is not a question. I'm a forensic psychiatrist. I don't do file review for free. I'm sorry. I better declare that. So if you had somebody who committed an offense and you require a forensic psychiatric assessment, there's something called legal aid rate. Justice pays that money. Is access to justice. If you deny and you let me suffer, I think there's an ethical concern about that. Should we be looking at a framework that allows me to go and get psychiatric assessment paid for by the public? Should we be looking at that if I needed an assessment in order to reduce my suffering? That's one question. Two, why is it that the public has to pay for it? If I had my money, why can't request for a psychiatric assessment? Why should that be refused? Because when you talk about criminal responsibility, fitness to stand trial, I can pay. I will pay. If I cannot pay, the public picks it. I think we should consider those two.
So I just want to make sure I understood the first point, which was that should we pay for forensic psychiatrists to provide psychiatric care in prisons? No? If they are requesting MAID? Sorry, I botched that.
You're saying the essential work here is file review. We do not have a system that pays for file review. Psychiatric outpatient, before you see psychiatrist, number, 2 years. Those are, because we don't pay for file review, you're not going to be paid. Nobody will do the job. So I'll continue to suffer. If I committed an offense, legal aid covers me. And legal aid takes, if I want to go to court and you question my responsibility because of mental illness, legal aid covers my assessment. Why are you delaying it if I was qualifying for MAID? You can ask that. Second, if I was rich enough and I could pay for myself, why deny me the right to get psychiatric assessment? It doesn't have to be public. Those are my points.
Yeah, I mean, like, these are really good questions. I don't think they're specific to MAID, really. I think you're asking really legitimate questions about the fee schedule. You're asking questions about, what people should be able to pay for privately if they want to versus publicly. I mean, I think this is a live debate everywhere in the country in its various forms and will continue to be. I think maybe the MAID debate puts a fine point on it because of what's at stake, but I think it's a version of the same conversation that we're having about all kinds of access to medical and allied health care.
Yeah, no, that's right. This is not just the MAID question. This is a question across the board. People should have access to appropriate services, but don't always. The idea of private billing versus private care plus public billing. So, I mean, that's obviously contentious, but people who believe in a public health care system feel that everybody should have equal access to services regardless of their financial abilities to pay. So if you end up having a mixed private service and a public service, people who have the money will get certain services. So it's a very contentious thing. This is a discussion in all areas of medicine. How much do you have private medicine and so on? So anyway, It is
We will have to wrap up.
12:30.
We will eat lunch now. This could go on. I think this is a a good segue into the discussion panel later, and I think it also speaks to how, whether it's intentional or not, the legal system was saying, the eligibility rests on the maid assessors and not the legal courts, and maybe whether they knew that would put the funding somewhere else or not. I don't think they did that on purpose, but that's kind of where it is now. There's no legal funding for maid assessment and access to resources. But anyhow, we will then eat lunch and then think about that over lunch. And so thanks so much again to the three speakers. And we'll reconvene in about an hour. Thank you. Okay. Good. Okay, everyone. Hopefully you enjoyed the lunch provided and had some refreshments and a chance to network over at the lunch hour. But we'll convene into the afternoon part of the sessions here. And the goal is to have our next speaker and then quickly move on to our discussion panel. And to be aiming around 3 o'clock is our goal. So we'll see if we can keep on task here. I'll just briefly introduce our next speaker, which is Mr. Brian Salty. And he's been the Associate Registrar and Legal Counsel for the College of Physicians and Surgeons of Saskatchewan since 1999. His primary responsibilities include general counsel for the college, preparing and presenting disciplinary cases, drafting bylaws for consideration, and representing the college in court matters. He received his education and bachelor in education in 75 and then his law degree in 78, both from the University of Saskatchewan. He's also a past sessional lecturer in administrative law at the U of S and in the MBA course in law and ethics at the U of S. He was also appointed a Queen's Counsel in 2009, received Distinguished Service Award from the Canadian Bar Association in 2016. And he was a member of the expert panel on the Council on Canadian Academies. The CCA was commissioned by the Government of Canada to provide reports on advanced directives, mature minors, and MAID for persons with mental disorders or mental illness. He testified on MAID issues to 2 parliamentary committees and led development of the College of Physicians and Surgeons guidelines on MAID. And his publications include the book, The Law of Professional Regulation, published by LexisNexis, and a number of other articles and publications on administrative law, especially those pertaining to medical legal issues. So please give a hand for Mr. Salty.
Thanks very much. Why is it that they always make these things for short people? Okay, now this will be the penalty for the next person who follows me trying to speak into it. Thanks very much for the opportunity to speak to you. I appreciate this. This is an area that is of real interest to me. And I apologize if I'm going to be doing some of a repetition of what you've already heard from some other people. But I'm going to try to skip over some of the things that I think that you've already heard and to focus on some of the issues that I think might be of more interest. So the first thing is just a land acknowledgement. One of the things that we recognize is that we are on First Nations territory. It's home of the Cree, the Dakota, the Saulteaux, and Métis Nations. And again, all of us would like to confirm that we wish to work together with the First Nations communities in order to try to achieve a reconciliation. So I do want to give that acknowledgement and thank you for the opportunity to do so. So this is a summary of the presentation that I'm going to put forward. First is, how did we get here? Why did the courts decide that medical assistance in dying was going to be something that was going to be required? An overview of the legislative requirements related to MAID, then the MAID eligibility for mental health disorder, which you're most clearly focused on, and a little bit of information about MAID in Saskatchewan from the latest report, because I think some of that is really interesting and raises some interesting issues with respect to psychiatry, even though medical disorder as a sole underlying medical condition is not in force at this point. So I have to give a disclaimer. The first of the elements of the disclaimer is that I speak for myself. I don't speak for the College of Physicians and Surgeons on some of these issues. The college, as you'll see in a later slide, has got 2 documents that are intended to guide physicians in providing medical assistance in dying. I was involved in the development of those 2 documents, but my other opinions are my own. The second thing in the disclaimer is, not surprisingly, I'm not a doctor. So while I understand the legal issues pretty well, I think I am obviously at a bit of a disadvantage when it comes to some of the medical issues involved. You as the psychiatrist will know vastly more about some of the medical and ethical issues as I think I will. So what does the criminal code say about this? The criminal code essentially says that it is a criminal offense to assist somebody to commit suicide. So if I happen to have a shotgun in my basement and my next door neighbor comes and says, you know, I just don't think my life is worth living, and I say, well, you know, I got a shotgun here. If you want to go and take it out, and that way it can be quick and easy for you, I've just committed a criminal offense. By assisting anybody else in order to commit suicide, that's a criminal offense. And that was the case up until the Carter decision that was given in 2015. And some of you may be familiar with the earlier Rodriguez decision, in which there was a challenge saying that this prohibition against assisted suicide is unconstitutional, and the Supreme Court of Canada said, no, we don't think so. We don't think that's inconsistent to deprive people. And when faced with the Carter decision, they changed their mind and said, no, we think that the restriction which says that physicians can never help individuals who are suffering intolerably by assisting them to die, that is unconstitutional. That's a restriction on their rights. And it's primarily a Section 7 charter right. Everybody has the right of life, liberty, and security of the person. And so one of the important things of this is that the legislation did not strike down the prohibition against assisting suicide in other circumstances. So it was and is a criminal offense for me to lend somebody a shotgun to commit suicide. And the only time that suicide or assisted suicide is permissible is in following the legislation in the criminal code for doctors and nurse practitioners to do that. So here was the declaration. Was that the criminal code and the prohibitions infringe Section 7 of the Charter, and they're of no force and effect, to the extent that they prohibit physician-assisted death for competent adult persons who, and the first thing is they clearly consent to the termination of their life. So that invokes all of the things that all of the physicians have learned about informed consent and giving all of the information necessary for the person to actually make an informed decision about their care. And the second, and this is the important part of it, or another important part of it, that the person has a grievous and irremediable medical condition that is causing enduring suffering that is intolerable to the individual in the circumstances of his or her condition. So, as you've heard in the earlier presentations, there's both an objective element to this, and then there's a subjective element. Because what causes intolerable suffering for me may very well be different than what causes intolerable suffering for somebody else. And I sometimes use my mother as an example because she's a quite marvelous person who can endure remarkable suffering and has in the past undergone dentistry, refusing all freezing because she just doesn't want it. Well, that's not something I'm about to do, but nonetheless, it's something that she does. So a circumstance in which I would potentially regard my suffering as being intolerable might very well be quite tolerable for somebody else. So that's a significant subjective element associated with medical assistance in dying. So these are the 4 criteria. Patient has a grievous medical condition. Condition is not remediable using treatment that the patient is willing to accept. And again, that's an important element of it. This legislation or the Carter decision doesn't require that people undergo experimental treatment or something else. At some point in time, the patient's entitled to say, no more. I'm not going to try this other therapy. And at that point, they're at if the condition can't be treated by treatments that they're prepared to accept. That's the end of it. And then the next part is that the suffering must be intolerable. I've spoken about that and how that is a significantly subjective element, and the patient consents to death, and I've also spoken about that. So why? Why did the Supreme Court of Canada say that this legislation that says that there's a prohibition against assisting people to die in some circumstances, why is that unconstitutional? Why does that infringe my right to be able to make decisions about my future? And this is the focus. The court's focus was on allowing patients to choose death as an alternative to intolerable suffering. So among the examples that was considered by the court was some patients may decide to commit suicide if they can't get helpful assistance that'll allow them to die in a relatively painless way through medical assistance in dying. Some patients who may attempt suicide may not succeed. Some patients may be permanently harmed and reduced to a stage of an even worse condition that they were before if they're not allowed to access medical assistance in dying. And then the legislation which prevented patients from making that choice, the choice to end their life, and prevented physicians from assisting, was unconstitutional. It infringed the rights, the charter rights of individuals. So what's the legal effect of the Carter decision? So the Government of Canada was faced with this declaration. Your legislation is unconstitutional. Saying that people cannot receive medical assistance in dying, saying that physicians can't assist that, that's unconstitutional. And if the government had not passed new legislation, that would have been the extent of the rules, that as long as the patient met the grievous and irremediable medical condition and the other things that I've referred to, that a patient would then be entitled to receive, or rather the physician would be entitled to assist the patient to receive MAID, and neither the patient or the physician would be in any difficulty. Another part of that is that the legislation couldn't contain anything that was inconsistent with the Supreme Court of Canada's decision in Carter. And the third thing that I think there's sometimes some misunderstanding about is nothing compels governments to provide this. Nothing requires physicians to participate in this. Nothing requires patients to consider accessing it. What it is that the Carter decision said, governments, you have to get out of the way. You don't necessarily have to establish processes. You don't necessarily have to do anything. But what you have to do is you have to stay out of the way, and you can't have legislation or other things in place which are inconsistent. So if I go back a long time ago to Morgentaler and abortion, it's very similar. Abortion used to be illegal in Canada. The Supreme Court of Canada said no. The legislation which says abortion is unconstitutional is a criminal offense. That is unconstitutional. And for the next year or two, the government tried to pass new legislation dealing with abortion, could never get consensus, did pass new legislation. So the result is that the issue of abortion is just simply not addressed in any legislation anymore, because what was there is unconstitutional and governments never got around to replacing it. So the legislation, so initially the legislation said that you could only access medical assistance in dying if you had a reasonably foreseeable death. And I expect you probably had some discussion about that and some of the challenges. What is a reasonably foreseeable death? That's not the point of my presentation today. But what is reasonably foreseeable? Because everybody in here has a reasonably foreseeable death. So far as I know, nobody has ever lived forever. And I have a reasonably foreseeable death. Maybe tomorrow, maybe 30 years from now, but I have a reasonably foreseeable death. I'm not going to live forever. So what does that all mean? So there's been a lot of discussion about what is reasonably foreseeable. It's something more than just your natural lifespan of the average lifespan of a Canadian. And there's been a fair bit of discussion that has evolved over time, which I think largely started with you have to be able to identify a particular condition. So here you go, you've got metastatic cancer, it's spread all through your body. We know from many people in that condition that you have a life expectancy of 3 months. You have a reasonably foreseeable death. And then the discussion broadened from that and went to, well, yeah, but what if you've got COPD and you've got this and you've got that and you've got high blood pressure, hypertension, and you've got, at some point, your combination of factors can give you a reasonably foreseeable death, even though you're not able to say your prostate cancer will kill you. Your COPD will kill you. So ultimately, the reasonably foreseeable death, I think generally speaking now, is based upon the constellation of conditions that an individual may have. And it's accepted that a reasonably foreseeable death exists if you have multiple comorbidities that will likely cause your death within a reasonable period of time. And lawyers love using the word reasonable because we can never be tracked down on what reasonable means. But it's something more than just there's somebody who's going to die eventually. It has to be closer than that. But what that means, and if you followed a lot of the discussion, what you'll probably have seen is that in certain parts of Canada, the rates of medical assistance in dying are much higher than in others. And so I think it's fair to say, it's certainly my conclusion, that what is a reasonably foreseeable death has been interpreted somewhat differently by different people in different places, but they all are doing the best they can to try to interpret what this means. So then, after 2019, I skip one slide. And then, in order to throw the wrench into the system, a decision came out of Quebec, and that was the Truchon decision in 2019. What that was a Quebec court saying, nothing in the Carter decision says your death has to be reasonably foreseeable. The Carter decision says your suffering must be intolerable. So where did this legislation come from that said it had to be a reasonably foreseeable death? Didn't appear in Carter, not consistent. What's the difference between somebody suffering intolerably, whose death is not reasonably foreseeable, and someone who is suffering intolerably and their death is reasonably foreseeable? So what what the decision said was, this is unconstitutional. It's unconstitutional to limit MAID to those people whose death is reasonably foreseeable. And the government of Canada had essentially, I suppose, 2 or 3 choices. One was to appeal it further. They didn't do that. The second was to simply say, well, in Quebec, these are the rules, because courts are provincial, except for the Supreme Court of Canada. So in Quebec, you can get a death if it's not reasonably foreseeable. But in Saskatchewan, it has to be reasonably foreseeable, and the government wasn't prepared to have a patchwork that applied across the country differently. Or the third thing was to develop legislation that said, okay, we'll expand the scope to patients whose death is not reasonably foreseeable as well. So after 2019, this is, again, just a very quick summary. The person must be eligible for health care. The person must be 18 years of age or older. The mention was made during the introduction of the Council of Canadian Academies. I was on the group that addressed mature minors, and this is not the topic of the conversation, but it was a fascinating experience to be in the same room with a lot of these people. And then that grievous and irremediable medical condition. And then the person must have made a voluntary decision to access medical assistance in dying. And person must have been given information about what is available to remedy their suffering, and they must be aware of what treatment is available, and despite that have concluded that medical assistance in dying is the appropriate way to deal with it. So 2 physicians can do this, or 2 nurse practitioners, or 1 of each. There's a bunch of other requirements relating to the medications, etc. Again, I'll just diverse for a brief second. The only form of medical assistance in dying that I understand is available in Saskatchewan is administered by nurse practitioners or physicians. But the legislation opens up the possibility of self-administration. So there isn't anybody who I understand is currently working with that, and there's some requirements that we have at the college, if that is to be the case. But if, for example, I was seeking medical assistance in dying and I wanted to administer it myself, the law does not prohibit that. The physician can get the medication, the physician can give it to me, I can self-administer. One of the requirements of the college is if that happens, there has to be a physician standing by to essentially finish the task if that doesn't work. There's been a couple of ugly incidents in which patients have ingested medications, vomited some of it up, and not been successful. So while it's not available as I understand it, it is not prohibited by the government's legislation. So I'm going to skip forward because I think that I'm coming reasonably close to my time, and I want to try to stay within the half hour. So if you were interested in doing this kind of work, and I encourage everybody to think seriously about it, there are the 2 documents that I think are going to be quite helpful. The College of Physicians and Surgeons has spent quite a bit of effort, I was part of that, to try to put together 2 documents, guidance documents for physicians. One is, okay, here you are, you're an assessor or somebody providing medical assistance in dying, and what do you need to think about, what do you need to do, what are some of the requirements? And so there's one document for patients whose death is reasonably foreseeable. There's a second document for those whose the patient's death is not reasonably foreseeable. And I think that it is much easier to try to deal with track 1 and track 2 in separate documents, so you're not looking at things which simply don't apply. And for example, providing advance consent to medical assistance in dying is available in a track 1 case. It's not available in a track 2 case, except in Quebec, which I'll talk about. So that's a college approach. And generally, a physician who wants to change their scope of practice has to apply to the college and receive permission. But we've looked at what the MAID program in Saskatchewan is doing and have said, if you've gone through the MAID program, you don't need any permission from us. You've already satisfied everything we would ask of you. So once you've been approved by the provincial MAID program, that's fine. That's all that you need to do in order to meet the college's requirements. So the first thing from Quebec, October 31st, and this is going to be an interesting change because I mentioned that you cannot currently, under the legislation, give advance consent to administration of MAID unless your death is reasonably foreseeable. And Quebec has just passed legislation and announced it that said, well, as a healthcare issue, if you have a condition that may deprive you of your ability to make informed decisions, you can sign a document that says, when I lose capacity, I want death. And so the example that's been given in the media is Alzheimer's. Somebody who has got progressive Alzheimer's can, while it is progressing, but they're still capable, say, if I get to a point with my dementia that I can no longer recognize my family, just inject me with the appropriate medications and let me die. And the government of Canada has said they won't challenge it. Nobody else has suggested they will deal with it that way. So we're going to end up with this, part of this patchwork is that the requirements in Quebec are going to be quite different. And of course, as psychiatrists, you deal with patients with dementia all the time. And so your patient may well be able to get medical assistance in dying in Quebec when they can't in Saskatchewan. An interesting political statement. Poilievre, and this isn't a political speech, but it certainly looks from the polls as though the Conservatives will likely form the next government. And Poilievre has announced publicly that if elected, they will remove the ability to provide medical assistance in dying for situations in which a mental disorder is a sole underlying medical condition. So if they're elected, the legislation, and if they follow through, the legislation will, for the foreseeable future, remain the same way it is now. There has to be a reasonably foreseeable death or a not reasonable foreseeable death based upon a physical condition. It can't be done solely based upon a mental health disorder. Then there's two interesting new charter challenges that are, this one was done when I prepared the presentation. And there's a court challenge right now saying the prohibition against providing medical assistance in dying for individuals with a mental disorder is unconstitutional. Just like it was unconstitutional to do so for patients who had a physical condition that was likely to cause death, just like it was unconstitutional for those individuals who didn't have a foreseeable death but had intolerable suffering from a physical condition. It's also unconstitutional with respect to patients who have a underlying medical disorder as a sole medical condition causing the suffering. So we'll see what happens with that. And then since I prepared the slide, there's now a new challenge that comes from a group representing the disabled, saying this unfairly causes problems for the disabled. The disabled are more likely to be subject to discrimination, and it may be used as a way in order to persuade people who have disabilities to access medical assistance in dying rather than being able to access the supports that they need. So these are two challenges which are obviously going in very different directions. We'll see what happens. They're both at the very beginning stage. So just a couple of things just from my perspective, to point out the different points of view that exist with respect to the MAID issues. The Council of Canadian Academies study I spoke about, I had some involvement with it. But what was interesting about that, and I didn't sit with that group, but what I understand was that there were very strongly held perspectives, and it was divided almost equally. So while the other two groups came up with a consensus report saying, here's what we think about these issues, there was no real consensus report coming from the group that was studying the mental disorders as a sole underlying medical condition. And so what they spoke about was that there's a different understanding of the information, there's a different appreciation of the consequences, that there was fairly strongly held views, and that partly what appeared to be the basis of the difference was the one perspective which focuses on patient autonomy and patients' right to make decisions, whether they are decisions that somebody from the outside would view as wise or not, and the group that was concerned about the potential, or about a couple of things. One was, of course, suicidality is associated with many medical conditions. How do you separate the suicidality that you try to treat with the desire for medical assistance in dying because they are suffering intolerably? And so there's the two sort of perspectives that, at least according to what I understand from the report, underlay the differences and why they couldn't come to any kind of a conclusion as to whether this made sense or they did not make sense. And the big question, how does one determine if a mental disorder is incurable? Because that was another question that was raised. Can you ever say that a mental disorder is incurable? Those people who think that you can say that is, well, maybe you can't say that in the first week of treatment, but what about the 15th year of treatment? At some point in time, you are looking at this and saying, this is untreatable. And I think of my next door neighbor with recalcitrant, very, very deep depression. I don't think anybody would ever say at a certain point in life that her depression was treatable or that she was curable. So it's one of those ongoing discussions that occur. So it's the weighing of outcomes. By the way, I saw somebody taking photographs. You can have this presentation if you want it. It's I'm quite happy to let anybody have it who wants it. So how do you balance the risks, ending the life of a person with a mental disorder whose condition could have been improved, and balancing that against the person who says, my suffering is intolerable, I just can't deal with this anymore, and I just, death is much better than this intolerable suffering that I'm experiencing. And how would the issue of how to and when to die, there's the discussion is here that some people felt that there was a clear distinction between the mental disorders being a basis for intolerable suffering and the physical disorders being the condition that's causing the suffering. And there was a clear distinction between the two. Others did not agree that this distinction existed. So I've already spoken about the challenge between suicide and the mental disorder challenge. How do you differentiate the desire to die from that is part of the pathology from the desire to die that's caused by the intolerable suffering and the desire to be released from it? So I'm going to skip over as I'm getting tight in time, but I just want to point out a few things at the end of my presentation. There are countries that do permit this. Belgium and the Netherlands currently permits medical assistance in dying for people whose mental disorders are the sole underlying medical condition. It's not new. The number of people requesting it is small. The number of people approved is small. But the evidence, such as it is, appears to suggest that there's pretty good consistency between the assessments, and so the concern that different people will have wildly different methods of assessing whether somebody's eligible doesn't appear to be borne out. The Association of Addiction and Mental Health has expressed some very real concern, saying there isn't enough evidence yet. We need more evidence before we can do this. I'll disclose my proclivities, I suppose. Where are you going to find this evidence? You know, it's not as though this evidence is ever going to come unless it's actually permitted and then you review it in advance. So while they say there's not enough evidence, we need more evidence before we can do this, I think to some extent it's a questionable proposition, because I don't think that evidence is likely to come unless you actually see it in operation and see what actually happens. And to the extent that you can see from Belgium and the Netherlands, it's not as though the sky is falling. At least that's the perspective that I have. So Dying with Dignity gives the opposite side of it. This is an organization that promotes medical assistance in dying and thinks that it should be made available, and it's an important part of the rights of individuals. They are clearly on that spectrum, on the side of the spectrum that speaks about individual patient autonomy. But what they refer to are a number of myths. The first myth is that recommendations that are being made to patients who aren't eligible to consider MAID is a myth. The legislation, the suggestion that people with a disability can then apply for MAID based upon only their disability is a myth. That vulnerable patients are not likely to access MAID, and that thinking that this is a way to get rid of vulnerable people is a myth. That the statement that somehow the poor, the disabled, etc., are being targeted is a myth, and that it's taking away from palliative and care resources is also a myth. So again, you can look at these slides. I'm afraid I'm running past my time. And anecdotally, what is interesting And again, this is anecdotal. I can't find any statistical support for all of this, but the people who are involved in this that I've spoken to is almost exclusively the people who are accessing MAID are educated, Caucasian, and reasonably well off. Those are the people who are making the requests, those are the people who are receiving MAID, and the number of the poor, the disabled, the individuals who are living in difficult situations who are accessing MAID is pretty small. So one of the things that is required is that there's a requirement that reports are prepared every 6 months that are given to the Government of Canada. So the MAID program does this. So here's some of the things that I find of some interest. The vast majority of patients who are requesting MAID are there for cancer. The other reasons are there: respiratory, neurological, cardiovascular conditions. The next thing is the number of assessments that are being done. You can see over the 6 months ended June 30th that the number of requests is approximately stable. The number of patients the number of individuals assessed, men and women, is relatively stable, so it's approximately the same. One of the issues that I found interesting in this report is, of course, many of these people may have some sort of comorbidity associated with psychiatric conditions. And if you look back to the roughly about 250 individuals who have been assessed, what you can see is somewhere in the neighborhood of 35 of them were assessed as having some psychiatric component to their situation, whereas the other 215 or so were not identified as having any psychiatric component. Again, you'd see the exponential growth from 2016 to 2023 in deaths. It appears to be leveling off. If you assume that it doubles, what you'll see is that it'll be around 350 this year in Saskatchewan. The other thing that's interesting is the blue portion is the ones whose death is reasonably foreseeable. The red portion is the ones whose death is not reasonably foreseeable. And so the number of individuals whose death is not reasonably foreseeable is tiny. 5 people in 2023, 2 people in 2022, et cetera, 4 to date in 2024. So the vast majority of patients who are receiving MAID are doing so because their death is reasonably foreseeable. Then there's the main conditions associated with MAID, again, cancer through to organ failure, very similar to the previous slide. And then the nature of the suffering. One of the things, again, that this is my own interpretation of this, but really strikes me is that for the huge percentage of these people, the suffering that they have is the existential suffering. It's not that they're in incurable pain. It's that they're being deprived of the things that they've always enjoyed. They're being deprived of what they regard to be their dignity. They are unable to enjoy the things that they once were able to enjoy. And that's the reason that these people are suffering intolerably, or say that they're suffering intolerably. And so another slide, one of the things that is frequently raised is, well, what about palliative care? Maybe if we had better palliative care, we wouldn't have so many people accessing MAID. And this report, the 6-month report, that there was about 27 of the individuals who were assessed in that 6-month period who needed palliative care but couldn't actually receive it. The rest of them either didn't need it or accessed it, or it was available but they chose not to access it. So while it still remains a significant issue, about 1 out of 5 should have received palliative care assistance. In fact, the other 80% either didn't need it or didn't want it. So medical legal issues, I was asked to speak briefly about this. You'll get 1 minute of this. So the first is that there is protection in the criminal code if you participate in MAID. The only time that you commit an offense under the criminal code is if you deliberately assess somebody as being eligible when you know they're not. That's what the criminal offense is. But if you're wrong, that's not a criminal offense. Even if you're careless, it's not a criminal offense, unless you're really, really careless. So you have very substantial protection from being charged with a criminal offense for assisting in MAID. And this is, again, just a personal view, but my personal view is assuming that you've gone through the appropriate steps to ensure consent, who's going to sue you? If you have gone through the appropriate steps and assess the patient as being eligible for MAID, and somebody later tries to question that, where's the damage? You did this based upon the individual's consent. The patient, presumably, if you've done your job, has fully understood what was involved, has fully agreed that their death was something that they sought for, and fully agreed to participate in the process that led to their death. So while there is nothing in medicine that is free of liability concerns, it seems to me that this is at the lower end of the concerns. And finally, the question of some people are concerned about complaints to the College of Physicians and Surgeons or complaints to some other body. What I can say is that we've only ever received one complaint, and that was a patient who thought that they should have been assessed as eligible and was assessed as not being eligible, and it was dismissed pretty quickly. So that's oops, I guess I'll go forward. So that's, again, some of the resources you might find useful if you were wanting to look at this. And I'd encourage you to read some of these reports if this is an area of interest to you. So thank you for your time. I apologize for running 5 minutes over, but I've been told I talk too much, so thanks.
See, this is what we were talking about earlier. I'm vertically challenged somewhat, so.
I was just on an airplane for 26 minutes.
Yeah, fair enough. I mean, statistically though, I would say I'm average height, you know? Just putting that out there. Appreciate the interesting talk, Brian. There's a lot of questions that I think will come from that. Maybe we'll group that all in with the discussion panel as well, in the interest of time and efficiency. So I'll invite the rest of the panel members up, unless you had a specific, yes.
Brian, this is just a question specifically for you. That's why I don't want to wait for the panel. I had shared with the group this morning the rationale behind the development of the model practice standard, one being, and the inclusion of the regulators in the revision and redrafting. And the hope being that you would all come together as a happy group and adopt it more or less similarly so that we could move towards a more harmonized scheme across Canada. And I'm wondering if you have any insights as to why the group did not do that, and each one sort of decided to take the document and do with it as they will.
Sure. You can start by blaming me, because I led the group. There were a few things that we frankly didn't like in the document. So what we did was to go through the document and say, we like that part and we don't have it as part of our college document. We like that part and we're going to incorporate it. We don't like that. So, and one of the things that I did not like is that I think that it is particularly challenging when you have significantly different requirements for death reasonably foreseeable and death not reasonably foreseeable. And so when you have within a document, ignore this if it's a reasonably foreseeable death, include this if it's not reasonably foreseeable, I think that introduces confusion. So I put forward my thought that maintaining the two documents was an important thing so that you weren't ending up with that cross-referencing back and forth. So that was the first part of it. And then again, I don't remember specifically what it is about the document that I didn't like, other than just being in one single document and I thought confusing. As I recollect, I was also concerned that it ventured into the area of medical disorders as a sole underlying medical condition. And the problem is we have no idea what's going to happen. So, as happened with the death not reasonably foreseeable, it doesn't look the same as death reasonably foreseeable. You can't give advance directives, there's a longer waiting period, there's a bunch of other stuff. So to try to incorporate what we don't even know what it's going to look like, is there going to be some, assuming that it does come into legislation, which I think is now a very questionable proposition, but even assuming it does, is it going to look like it currently does, which is essentially the same treatment, whether it is a physical condition that is causing intolerable suffering, or a mental disorder that's causing an intolerable suffering, but in both cases death is not reasonably foreseeable? Is it going to look the same, or is it going to look extremely different? So, among the things that has been tossed out there is the whole question of, if it is a mental disorder, does it have to be a psychiatrist doing the assessment? What about the shortage of psychiatrists in different parts of Canada? So our approach, at least in terms of the mental disorder issue, was we'll cross that bridge when we get to it, if we get to it, when we have better information about what it's going to look like, and then we'll update our document at that point in time. So there's also some differences in privacy legislation, province by province, which also produces some challenges, because our privacy legislation, frankly, is very different than what exists in Alberta and Ontario and a couple of other provinces. Age of consent is different in Quebec and New Brunswick than it is in the rest of Canada. So all of those things were things that caused us to look at it. The ones that did adopt it were the ones who didn't have anything before. And so I think Newfoundland, I think New Brunswick, I think there were a couple of others who had no guidance for their physicians, and we already had it's a whole bunch of pages if you've read it, that talks about, here's what you have to do, here's the things that we think you should do. And I guess the long answer is we just thought that we had a better product.
Thank you.
All right, thank you for that question. And yeah, maybe now we can invite the rest of the panel members to the front. And I may just stand here at the front then to moderate. It's probably easiest. And I'll first, as people make their way up, for sure. Yeah. I'll ask Dallas if there's any questions. Otherwise, I have a few topics. Or if anyone has a question they were thinking about to ask the panel. We have Dr. Badani. And before I do that, I'll just say the overall objective and topic of the panel is future directions and challenges in MAID for mental disorder or medical illness as the sole underlying medical condition, and how this might dictate policy and practice. So it's a broad topic for a reason, and more so just to generate some discussion, also based on what has been said already. So I'll let Dr. Badani start. She had a question for the panel.
Thanks so much. I'm just wondering if the legislation does pass, and how you think that it might affect the application of the Mental Health Act the way it stands now, just given that, at present we're involuntarily admitting patients with suicidal ideation or post-suicide attempt who may very well have capacity, and so how you reconcile sort of the value of autonomy as we think about MAID versus autonomy in that kind of context.
Thanks for that. Thanks for that question. So first, just a clarification. The legislation as it currently stands says that a mental illness is not a serious illness, disease, or disability. But that on 3 years forthwith, that will change. So nothing has to be passed. That will expire automatically in March of 2027 unless there is a new piece of legislation that says we've changed our minds or there's going to be another deferral, what have you. So the model practice standard actually addressed this point very directly, saying that a request for MAID in and of itself by a person with a mental disorder, in the absence of any other indications of suicidality, intent, plan, past attempts, etc., is not in and of itself grounds for hospitalization under provincial or territorial mental health legislation. And on the flip side, and as I spoke to this morning and has already been integrated into the CPSS standard, a request for MAID should be enduring, unambiguous, repeated, and not made in a time of crisis. So given that involuntary hospitalization occurs in times of crisis, those two things, the way we had laid them out in the standard and has been adopted here at least, they're not in conflict. Do you want to add anything?
If it's useful to say I agree, I agree.
So this, I had a question just geared toward mainly the clinicians on the panel, but anyone can weigh in. It's more so how do we define like treatment exhaustion? And you mentioned treatment-resistant clinics that exist in certain parts of the country, but from what my understanding is we still don't really define treatment resistance very well for many of our disorders, whether it's treatment-resistant depression or severe persistent mental illness. There is no good definition. There are consensus, but still it really varies. So how might we tackle that problem as we move forward to meet that criteria of incurable?
I had trouble hearing all of that. We're getting a bit of bounce back of the sound, so if Mona heard it, you go ahead.
Well, I'll tell you what the question was. And you
Okay.
Okay. He said, how are we going to, we don't have great definitions of treatment resistance for a number of different conditions, so how are we going to figure that out in order to know if somebody has an incurable condition?
Yeah, that's right. So what it's going to mean with mental disorders is that there are going to be a large number of things tried over a period of time, which might be a number of years, to establish that there really has been no progressive improvement of any of those. So treatment resistance in a MAID context is going to mean very considerable time involved for someone to actively engage in various treatments. So the case I presented this morning of a guy who spent a lifetime in treatments for bipolar disorder, in his 70s, ECT even only worked more than 2 weeks. That would be the kind of person for whom it's clear. So treatment disorder resistance is not going to be something very quick. It's going to be something to be assessed very cautiously and carefully, and we don't know theoretically if in 30 years, 40 years down the road something might show up, but then that's the same thing as with cancer. So if you have a cancer, we approve people for MAID because they don't want to have, nothing's working for it. Do we say they have to continue because theoretically something could show up in 30 years? We don't say that. So I think it's going to be a fairly significant series of trials of reasonably available, efficacious treatments that fit the needs of that patient before one is going to be able to say that the person has treatment resistance. And we all know that there are people that don't respond to anything, whereas others might respond very well. So this will have to be a very carefully considered, cautious decision, which is not going to be quick.
I'll actually say more than I agree. I think one of the challenges is the search for certainty, which almost never exists. There's only degrees of confidence. So the point that Dr. Thorpe made, which is that when you have a physical condition, how do we know that a magic drug won't appear on the market a month from now that we know nothing about that might potentially be a treatment? We don't. You can't say there's a zero possibility. You can say it's extremely unlikely. How do we know that a patient with a psychiatric condition that has been treated for the past 20 years without improvement and with horrible sequelae, there won't be a magic drug available a month from now that'll cure that? You don't. But again, I think we all live life by probabilities. If you want to be certain about everything in life, you'll never do anything. So again, I perceive this as a situation in which you use your best judgment, you use the best medical evidence that you have got. Diagnoses are sometimes wrong. Treatments are sometimes wrong. Every physician, I expect, that has been in practice for any length of time can look back on a patient and said, if I knew then what I know now. But that's not the measure. The measure is, did you turn your mind to all of the relevant information? Did you consider all the relevant information? Did you make the best decision that you could based upon the information as you had it at that time? And if you did, you've made a defensible decision. So, as I think was probably somewhat obvious, along that spectrum, I lie towards the patient autonomy as being a more important value, but I'm a lawyer. And so I guess all that I could say in addition to what I've already said is that, yes, it may be uncomfortable making decisions with less than perfect evidence, but you never have perfect evidence.
Could I respond as well? Yeah. I mean, I'm going to sound like a broken record, but I mean, I think I would give it back to you and say, like, we don't have a definition written down somewhere that everyone agrees to treatment-resistant fibromyalgia or treatment-resistant Ehlers-Danlos syndrome or treatment-resistant X, Y, and Z, and yet somehow our colleagues are reasoning through those cases, and that's why I showed you the case example of the patient who requested on the basis of fibromyalgia, and he was declined, by the way. The clinicians really carefully went through all of those elements I showed you. What kind of duration and quality of treatment has he had? What has he had? What about experimental treatments? Have we got the right diagnosis? So they reasoned through the problem, and I think the way that Lillian and Brian are describing, and came to a conclusion in his case that there actually were several more modalities that could be tried, and then condition was found not to be incurable. I had one more thought, but it was about Brian's excellent certainty point. Oh yes, I mean, I think the certainty point, I mean, I think I would push the logic even further. I mean, whatever your diagnosis is, how do we know that if for whatever reason your MAID provider suddenly went on vacation or was unavailable and you didn't get MAID, you might have changed your mind the next week? We don't know, and that has nothing to do with what your diagnosis is. You could have Crohn's disease and have changed your mind the next week. You could have cancer and have MAID on Monday, but actually on Tuesday have changed your mind. So that uncertainty is there in clinical decision making. And the last thing I want to say is I want to bring you back to the very first case I shared with you today, which is one that really stuck with me in my practice, of the patient who made the massive acetaminophen overdose and had blown her liver. And then the question is, should she be on the transplant list? You know, like, it wasn't comfortable or easy, but somehow we all agree that we should be able to make these decisions. There's tremendous uncertainty in that. We're basically saying, we're not going to recommend you for a surgical intervention that's going to save your life, but yet we're not asking those same questions. There was tremendous uncertainty there, but we put the information together as best we could, and we made the decision. So I'm not sure that this is all that different.
No, thanks. Thank you. Can you hear me, Dr. Thorpe? I appreciate all your insights, and I mean, I don't think there's a good answer to that question yet, but certainly when you reframe it this way too, maybe it's not asking the right question with regards to treatment resistance in particular, but more so, we're not treating diagnosis at all. Or considering just the diagnosis, it's more to it than that. There's a couple times mentioned already today about equity, access, jumping the queue, mentioned several different times in several different ways, and I also kind of want to hear from Lori's perspective too on this, about kind of your view from a provincial wide thing. You said we fill in the gaps too. We kind of play this secondary role, which maybe we didn't anticipate we'd be doing. Can you give us advice on how those we work one-to-one with patients, how we might advocate for more support this way, but also where do you see the MAID program itself kind of generating more support for services like across the board? And also, on top of that, how we might then bridge the gap with places that are much more rural, right? Like what have you seen practically work? You mentioned virtual assessments for sure, but is there anything else that we can do to increase our capacity?
That's a very good and long question, and there's a lot to unpack with that. So with the program, like we approach every patient in their own individuality and their own set of circumstances, which would include where they are located within the province. So in terms of you as psychiatrists, I think without being able to fully understand like what your limitations are currently, that's a hard thing to answer. So I'll use the example of Isla Cross. So Isla Cross has a group of physicians who are very involved with their patients' care, and really they had a patient in their community that wanted MAID. None of those none of those practitioners knew much about MAID, and none of them knew how to provide that for that patient. So they accessed the program. We set up like some education for them. We provided with shadowing opportunities, with just happened to happen in La Ronge. So and then one traveled to watch in Saskatoon, and over the course of 6 months, this patient got to the point where they wanted to have MAID. So we got that all in place. But when we visited that location, they have like everything. They've got a dietitian, all these different little areas and people that come to their community. But the one thing that they were missing in that community was mental health. And there was someone that was identified to be going there, but they were unwell or they hadn't seen them for months, and there was just that lack of communication as what was happening. So I think for a group of practitioners, I think if in the rural sites, they just don't even know what's available to them. So I think, like if the college or if the College of Psychiatry, if they just could communicate out to them to tell them what's available, that would also extend to us, because we are always looking to connect people where we can. And when we hear of something, we make a point of logging it in this quick reference book that we have, and to try and help people where we can and connect them where we can. And sometimes there is no opportunity for that, but for the most part, just that effort in advocating is probably reassuring for the patient. But we can't help everybody, but we try. Does that answer it?
No, thank you. Oh.
Okay. This wasn't directly about this, but I wanted to comment on something that we heard before from Brian, which he some of these myths about MAID. So that one of them was about the poor, uneducated people with no jobs who would be applying for MAID. So we did a QI project with a summer student, and she dug out all of the records. So I'm an obsessional record keeper, and so I have in there with my assessments what people did for a living and education and stuff like that. So she pulled out a lot of that stuff. So it was very clear that it was it was very rare that somebody applied in the first few years anyway for medical assistance in dying that wasn't a highly educated, well-to-do person. So it was a thing that people knew about. So what I'm seeing over time, and it would be kind of neat to do another QI on it now, because I have a lot more patients in my data file, that I think it's changing a bit, because when we're seeing patients, almost always now, they've talked about someone they knew who had it. So I'm increasingly seeing people who are not the highest educated, but they know about this. And so I think there were myths, but it is still true that the predominant of people not applying are the ones in the lower socioeconomic strata, because they don't know about it and they don't know how to access that service either. It's still predominantly well-educated people, but gradually it's sort of becoming more generalized knowledge, which is interesting. And I already talked about the fact that MAID for pain and lack of access to palliative care was just not true. And most most of our patients have seen a palliative care doc, and we've tracked that. And so a lot of this stuff is out there that has been a myth, but partly because people are afraid, and there's a long history. Some of us who have roots in Europe during Hitler era of people being, put to death without their wishes. The euthanasia wasn't euthanasia, it was without consent. So some of us have always been worried about partially because of that, but I think many of those things are coming out not to be true. So much as everybody's pointing out, we have a lack of services in many areas, and there's still, what do we do about it? Well, we can't. One can't fix everything. At least the MAID program can't fix anything. This is a societal thing that we have to decide how to better support people with a variety of mental health issues. How do we deal with that? How do we deal with the substance abuse that we're seeing that are coming in and out? And we get them better in hospital, they go out again. Like, what are these things? But a MAID program can't deal with all of those societal issues. We can do our best by attaching people to services, probably almost better than anybody else can, because we're very motivated to do so, but it's not perfect.
Thanks for that, Lillian. I just wanted to say one more thing. I think you all noticed that when the slide that showed the types of mental disorders that we were seeing, at the very top and the longest amount was chronic complex pain, and you're like, well, that's not really a mental disorder. But that one slide, so we have federal reporting, but we also keep some reporting that we provide to the Ministry of Saskatchewan. And the Ministry was interested to see if there was some sort of correlation between the amount of people that had chronic pain, if there was the same amount that were having depression and asking for MAID and that sort of thing. So we're seeing that we just have people with chronic pain that aren't treated, is really what that slide. But we, just to capture something on chronic pain on itself, was just not going to join the two together for the Ministry. So that's just to explain that slide.
It's like Dr. Ahmed, you have a question?
Yes, I do have questions. And I would just direct it to the panel. I think the only question that I'm sure of is to Dr. Gupta. When you started, you made a distinction, and I asked you during the break, between illness and disorder, and that you choose to use illness. Why? To Mr. Salty, you indicated that the reason you chose not to have psychiatry or psychiatrists as a member dogmatically, or to say yes is psychiatry, is because of access. You don't have enough psychiatry. Will I be right to say rationing become a motive? That you're rationing access to psychiatry, and consequently, you're saying we're going to have any other profession to decide on that. Secondly, he was 45. He committed murder. He was incarcerated, and he had stayed there. Right from the day he was incarcerated, this individual said he did not commit crime. The only disorder was personality disorder. He starved himself for 286 days. To go into the jail is to perceive ketone as soon as you enter the cell. If you were to request for MAID because of the suffering, what's your advice as a panel? Thank you.
I can try to respond to the one question you had. I must not have expressed myself clearly. What I was speaking about was the speculative potential of there being further legislation to deal with individuals that have a mental disorder as the sole underlying medical condition, and the potential that will exist in March of 2027 unless the legislation changes to have them included as part of the group eligible for MAID. The point I was trying to make was, on a national level, there are a number of different discussions about should there be additional criteria. So it wasn't my statement. For example, the group that I was involved with the Council of Canadian Academies, dealing with the individuals, minors who have capacity. One of the discussion elements was, if that's going to be allowed, should notification and consent of the parent be required? So it's really addressing the question of, might there be legislation, and if so, what might that legislation say? So I'm not sure it's a completely satisfactory answer, but what I was trying to say, Doctor, was that in the discussion about if there is to be legislation that will allow made for individuals who have a mental disorder as their sole condition, one of the things that is being discussed is that the legislation might say you're not eligible unless a psychiatrist has been part of the assessment. The people who oppose that as being part of the legislation say, but what might that do then to the availability? Because perhaps then people in especially some more rural areas simply cannot get assessed because no psychiatrist will see them for that purpose. And from what I understand, if you compare it to physicians who practice in other areas of medicine, there are a higher percentage of psychiatrists who are resistant to participation in MAID than there are internists and family doctors and surgeons and others. So it was a comment about what the legislation might say. It wasn't a comment about what a standard from the college might say or what I personally think. I just limit myself to what, if there is legislation, what that legislation might say.
I'll do the easy question on illness versus disorder. It's a long story, but I'll try to keep it short. So the Canadian Council of Academies working group that Mr. Salty referred to was given a name and a mandate from the federal government, and that was the first time, really, in the public conversation about MAID, we were talking about people with psychiatric disorders. And the name of that group was Mental Illness as a Sole Underlying Medical Condition. And the group said to the government, you really shouldn't call it that. You should call it Mental Disorders as a Sole Underlying Medical Condition. And the group renamed itself and named its report as such. When the federal government constituted the expert panel on MAID and mental illness, it once again used the formulation mental illness, and once again the expert panel said, you really shouldn't use that expression, mental disorder is the clinical term, but since it was in law, we could not change our title. We had to be known as the expert panel on MAID and mental illness, but throughout the report referred to mental disorder. The government, when it chose to write an exclusion for certain people, chose again to use the expression mental illness, and it is clear from the associated documents that accompany the legislation that that was intentional, because I think, now I'm guessing what was in their minds based on what was in the documents, that they thought mental disorder would exclude certain people from access whom they did not want to exclude, namely people with major neurocognitive disorders. So they chose to use the expression mental illness, thinking that it restricted the group of people who would be excluded and would ensure that people with major neurocognitive disorders would not be excluded. Oddly, I think, just from a clinician's point of view, if you look at this document where they say people with major neurocognitive disorders are not excluded by the exclusion, they also name people with autism, people with developmental disabilities, and people with ADHD, I believe. So as a clinician, it's really odd to think somebody with, like Lillian's patient, who is treatment refractory for decades, is excluded, but somebody with autism is included. But in any case, that's not in the legislation anywhere. All we know is that a mental illness is not a serious and incurable illness, disease, or disability. What the federal government thinks about mental disorder, we don't know. A fun fact is that mental disorder appears in the Criminal Code of Canada some 24 times, I think. Correct me if I'm wrong, Brian. The expression mental illness appears only once, and that is in the MAID legislation.
And Dr. Ahmed, I think your third question was more of a case example type of question. I think it was a person who was had committed a criminal offense, then was brought into facility, and then had a personality disorder as the primary diagnosis, was in for 286 days on a hunger strike, and then subsequently, what would the response be if this then individual requests medical assistance in dying?
So, I mean, I don't know if it's a real case or a made-up case. I think I would maybe reason by analogy here, and I'll invite my colleagues to do the same. But I do recall that in the early years of the Quebec regime, so the Quebec criteria was actually that the person had to be at the end of life. So it was perhaps a little bit more pointed towards terminal phase of disease. There were already people, so this is 2015, late 2015, early 2016, people saying, you know, this doesn't seem right. What about suffering people who aren't imminently dying? And so there were people who chose to go on hunger strikes in order to essentially deteriorate to the point where they were at the end of life. And I think the idea was that if somebody makes a request and they fulfill the right criteria, they fulfill the criteria. So by analogy, if this person has starved themselves to the point where I assume after 286 days, their natural death is reasonably foreseeable and they fulfill the other criteria that exist, that in principle they're eligible.
They probably have some organ disorder too.
Exactly. Do you want to add that?
I was just going to add that they probably have some like organ dysfunction at that point, and they didn't? They did not? Okay. Oh, wow. You should go on Survivor.
They only had tea and sugar every evening. They've emaciated so severely. And that's the cause, that's the fear for forensic practice, because the primary mental disorder is a complication of the mental disorder. So I was just wondering, with the suffering being is a secondary suffering, does it matter?
Well, yeah, go ahead. I was just going to say, since I've been part of the program in late 2022, I can remember 2 patients that have come forward with anorexia that we're trying to make an application for made. Like, we went through due diligence, through the intake and everything else, and got to the point where they were assessed. But at that point, we weren't assessing just about the anorexia. We were just looking at what medically had happened to them. And there, at that time, was not enough to show that there was a serious and irremediable medical problem. Go ahead.
Maybe I could add a couple of things. Again, I go back to my disclaimer, I'm not a doctor. But it seems to me that one of the challenges in what you're speaking about is the connection between the personality disorder and the intolerable suffering, and whether that was in fact what was occurring, or whether it was the incarceration and the person being incapable of going to the outside. Now, that may very well be intolerable, but that's not a medical condition. The fact that you are locked up and only able to look out through your window, at least I would be surprised if that was regarded as that. So where I had the difficulty in the connection in the example you gave was the medical condition incurable, causing intolerable suffering, because it seemed to me the suffering may very well have been the result of the incarceration, not as a result of the personality disorder. The personality disorder may very well have caused the person to want to starve themselves, but again, I wonder about that connection. The other thing that comes to mind from this, and I didn't speak about it to any extent in the presentation, is one of the things that has been an ongoing theme is the question, is there a difference between standing by and allowing an individual to starve themselves, to dehydrate themselves, and generally speaking, most practitioners, except in a situation of a serious psychiatric disorder, will look at it and say, It's unfortunate that you're going to choose to do that, but if that's what you're going to choose, I'll stand by. I'm not going to put IVs in you. I'm not going to sedate you. And if you choose to die that way, then you choose to die that way. And the ongoing debate as to whether there is a different ethical principle that applies between standing by and doing nothing and let the person starve themselves when you could intervene, and standing by and injecting certain chemicals into their bloodstream that actually causes their death. Is there a difference between them? And you'll get ethical debates about that and people who feel strongly about that. The first Carter decision, after having heard all of the evidence over multiple days, the judge's decision said there isn't any real difference. It is the same ethical issue. That didn't go to the Court of Appeal, didn't go to the Supreme Court of Canada. So part of what is the challenge, and you may very well have heard the news story from, I believe it was Calgary, where the young woman had decided that she wanted MAID, was assessed as being eligible for MAID, and her father then challenged in the court the process that was adopted by the program, not the individual clinician's decisions, which he said, I can't challenge that. That's their decisions. They've assessed the patient as being eligible. That's not something I can deal with in court. But what I can deal with is, did the program follow the right processes? Was it an unfair process? And initially gave a court order that said, no, you can't administer MAID while I'm dealing with this and while it's before the court. And the young woman then just stopped eating and stopped drinking, to the point that she was clearly going to die from this, at which point the father withdrew the objection and said, well, I guess it's better for her to die in a more humane way rather than through desiccation. So, again, I'm not sure it's helpful, but it does, I think, point to something that is worthy of that ethical discussion. Is there really a difference between allowing patients to make very bad decisions which result in their death, or at least what most of us would regard as very bad decisions, and actively accepting the fact that a patient in certain circumstances has a right to make the decision and access MAID in a humane and respectful way? Again, I disclose my biases.
And to segue from the realm of forensic psychiatry, and I just have a hypothetical question, or more just to put it out there, a question, and then more of a practical one. So the hypothetical question is there a role for independent legal aid for those applying for medical assisted dying, to have someone go through the legislation with them, discuss, what you're doing is reasonable within, federal regulation? Is there a role for that? And then secondarily to that, more practically, you mentioned there's not much risk for litigation. Is there risk for legal recourse from families of patients? Has that ever occurred? And who do we practically call? I mean, I will call the CMPA when I need legal advice or medical legal advice. Is there anything else that we should go towards for support regarding these issues?
So I'll start off, and I'd encourage any of the rest of the panel to respond to that. I'm a lawyer. I like lawyers. Lawyers should stay within their framework. These are not legal questions, I don't think. I don't think that they should be legal questions. Ultimately, it is the medical judgment of the individuals who are doing the assessment. And yes, there is some degree of uncertainty. And we spoke earlier about the lack of certainty associated with diagnoses and other things. But I just don't see how that's a legal question. So if I was hypothetically involved in a situation in which I was brought in to advise a individual who was seeking MAID, what do I tell them? Well, you've got a right to make the request. You've got a right to refuse. Ultimately, it's not your decision whether you're eligible, it's the doctor's decision whether you're eligible. I just don't know what other advice I could conceivably give, or what benefit I could have in that situation. And I don't think it's a legislative interpretation question. It's rather these questions which are almost exclusively medical. What is a grievous and irremediable medical condition? What's incurable? I can't give a patient help on those questions. So as much as I like lawyers, and I think that we should all hug lawyers, I just don't see a role for lawyers in that particular scenario.
So I can't always hear everything, especially if people are really close to the mic. It gets a bit garbled sometimes, but I think you're asking, sort of in terms of medical legal complications or adverse effects of being involved in MAID. That's, I think, what you're getting at, right? So with all the people who have accessed MAID and all the people who have been involved in MAID over Canada, it's remarkably surprising how little medical legal impact there has been on them. The ones that I'm aware of are often related to, maybe not quite following the processes as well as somebody else might. I think sometimes there was that case in BC where there was a person taken out of a psychiatric unit who'd been certified, and there's some of those cases that you have to wonder a little bit about. Most of us maybe wouldn't get into. The other case I thought about when I was in Halifax hearing about was that the case where there was not really family discussion and something happened quite quickly without involvement of the family discussion. My sense is that families take some time to get around to the idea sometimes, and if one was to jump quickly without having good family communication, one puts oneself to higher risk. So I think sometimes putting off a decision until you get a chance to have a family get their heads around it really reduces the chance of someone feeling that something might have been bad because they don't know what's happening, so they can imagine something bad and wrong happening if they weren't really involved in those discussions. So I honestly think I'm more likely to get sued by somebody whose license I might be involved in losing the license, right? Because people are pretty mad at me for that. But I don't see a huge medical legal risk, although I personally keep great notes of everything I do. You never know. But I don't think we have a huge risk of this happening, and very few cases. Lots of people are doing MAID out there. This is increasing numbers everywhere. We're not seeing this great number of litigations. It's not there.
Maybe I can point to the difference between the Canadian and the American legal system. I don't want to speak about the American system, where everybody can sue everybody for every reason. But in Canada, generally speaking, you don't have a right of action based upon something that's happened to somebody else. There's one exception to that. And that is in a situation in which you have you've suffered a loss as a result of the death of somebody else. So your spouse who contributed a bunch of money into the family dies in a car accident. No longer do you have their income to assist you. You can sue for that. But that's about the only situation in which you can sue based upon something that is harmful to somebody else. So where I would find it very difficult to imagine successful litigation is in a situation in which you have a family member who says, I have a right of action because my family member should never have been allowed to access MAID, and I have personally suffered this loss. Theoretically, is it conceivable? I suppose, the person whose death is not reasonably foreseeable that would have earned a bunch of money. So you, like other things, very little in life is zero, but some things come damn close. And this would one of those that comes very close. So if, and that was part of the reason why I referred to the sole complaint to the college that we've ever dealt with, wasn't from the concern that a patient had been assessed and given MAID when somebody thinks that they shouldn't have, but rather from the patient who said, I'm suffering intolerably, now I have to continue to suffer intolerably because those doctors won't give me access to MAID. So is that theoretically possible that could happen? Again, nothing zero, but this is coming real close. And again, simply because somebody disagrees doesn't mean that there's a cause of action. CMPA is a very powerful organization. I'm not going to spend a lot of time talking about that. That's a whole different topic for a whole different time. But One of the things that I certainly will give CMPA kudos for is that they are very thorough in defending physicians. It's not like the American system where the insurance company looks at it and says, hey, we can settle this for $100,000 and it's going to cost us $200,000 to defend it, so let's just write a check and get it over with. CMPA won't do that. So risks, almost zero. But if you're practicing medicine, there are risks. You know, roughly, when I last looked at the statistics, roughly half the doctors in Canada at some point in their career are going to be sued. That's about the number that used to exist. Whether it's still that number or not, I don't know. But successful actions are infrequent, and CMPA can be quite thorough and will provide an excellent defense of that, whether the complaint is to the college or the complaint is whether it's a court action or whether it's something else. You have somebody at your back.
You know, I think you'll get more complaints about us for not doing it as the years go by.
Yeah. Sorry, I'll just add one more thing.
And that's okay. I told them before that there was a case involved in which there was a complaint that I didn't approve someone. So you're not breaching anything by disclosing it was me.
I give very little detail.
Feel free.
Just a general outline. But the other thing is that, and this is perhaps my paid commercial announcement, or not paid commercial announcement, that everybody makes mistakes. Everybody makes difficult decisions that are sometimes wrong. And there are those out there who are worried that somehow they're going to lose their license or somehow that they're going to have horrible consequences upon them if, in fact, something's gone wrong and the college is just sort of waiting to jump on them with their jackboots and take care of them. And I've only done the work for the college for 39 years. So it's been a while. And that's just not simply true. Yes, there are people who there's certain conduct that they engage in that is beyond the pale, and you need an aggressive approach. But there's a recognition, and it's doctors that are making these decisions there's a recognition that what you need to do is to have a proportionate response to whatever the concern is about a doctor. So is it proportionate to send a letter of advice saying, you know, next time around maybe you should think about doing it differently and do it this way? That's sort of one end, and the other end is you don't have a license anymore. But that's reserved for the really truly egregious cases. That's the sex with your patient. That's the fraudulent billing of the system, pure fraudulent billing. Those are the kinds of things that are addressed from the most aggressive response. Serious ethical failings. But just doing your job and doing the best you can, making a mistake, that's not going to result in significant action you need to be concerned about.
I think every resident here is much more relaxed after that statement. Appreciate that vote of confidence.
And hug your lawyer.
Yeah. I might have time for one or two more questions, if there's any from the email. And I have two focused questions to close the day. First one would be just, as a clinician, then how do have you noticed an impact on the therapeutic alliance of patients that you're treating who request MAID or looking into MAID, and how you navigate that with the patient, the family? Have you seen any impact that way on the therapeutic alliance?
Navigate patients who what?
The impact on the therapeutic alliance.
Oh, impact on the therapeutic alliance. Well, we're often different people who do a MAID assessment versus somebody who's got the therapeutic alliance with the ongoing patient.
Yes. I meant also more not as a MAID assessor, but as a provider, and then your patient then is looking into MAID. Have you any experience that way as well?
No, I don't know.
I'll respond based on things that we've heard. I feel like the bulk of people in healthcare don't know when they should mention MAID to the patient. They don't know how to mention MAID to the patient. So the program has, on the intranet, the SHA intranet, there is contact information in there, but there's also, we've created like an introductory pamphlet. So you could print it off, hand it to the patient. You don't have to try and apply your interpretation of what all the information that was said here today. You just give it to them. Within that pamphlet, there's also some information about dying with dignity and other end-of-life options. So that gives the patient a little bit of their own ability to research and digest that information. If they need more than that, then we have a booklet for patients and families that goes into a little bit more about how people are eligible and that sort of thing. We don't want people to decide whether they're eligible or not before they come and talk to us, because every person has some sort of level of complexity or individualized kind of issue to themselves. So whether she's eligible, I might not be eligible, but we might have the same diagnosis. Like there's different things to consider, and we don't want any healthcare provider to ever feel that obligation. Just direct them to the program. We will apply due diligence. We will take each case for what it is, pull their medical, send it to the assessors, and then either they're eligible or they're not. And so that is, I think, the only issue, that people don't know how to approach it.
And I guess moving towards the future, I mean, assuming legislation doesn't change and it does come forth in 2027, as it's currently outlined, I just would ask each panel member, is there one kind of take-home pearl or something that we should be legitimately working on in the next 6 months, 1 year, to prepare ourselves for this or support the processes that are trying to be implemented? For me, the first thing I'm going to do is read the CPSS policies again. I know I'm going to do that. So that's kind of what I'm asking for. I just want one statement or take-home thing you would recommend for the audience today.
Can I have 2 pearls?
Feel free to give 2 pearls.
Thank you. I'm from out of town, so I get 2. So we've discussed in a lot of detail today all the different kinds of mechanisms and processes that are possible to develop right now. And I think that Mr. Salty is right. There is inevitably going to be regional, provincial, territorial variation in MAID programming, in who your practitioner complement is, who your patient population is, et cetera. But we do not need to wait for the federal government to decide anything to develop those mechanisms. So if what you need right here is a complex case table, develop a complex case table. If what they need in Ontario is a navigation system, develop the there's nothing to wait for. Whatever you think will better support MAID practice in your jurisdiction, we can work on that right now. But I don't think there's going to be a one-size-fits-all for that. But my second pearl is this. Those of you who have followed the debate as it's been unfolding nationally will know how polarized the discussion about MAID for persons with mental disorders has been and has continued to be. And I think one of the unfortunate consequences of that has been relatively low engagement by psychiatrists in MAID in general. And on the one hand, saying, we need to have evidence, we need to have guidelines, psychiatrists need to be assessors, but then not getting involved to support the program when they need a psychiatric consultation or when somebody has a comorbid psychiatric disorder, and being available to provide advice. So I think the more important pearl is engage in whatever way feels ethically right to you, but the disengagement that we have had, I think, as a professional community has been disheartening to our colleagues in other disciplines. And I will share one last anecdote that Lillian can confirm. We organized a knowledge exchange event in Montreal last year where we brought together experienced MAID assessors and providers and psychiatrists from every jurisdiction in Canada. And it was both heartening, but I also felt kind of ashamed when I saw how incredibly grateful mostly family physicians, but some nurse practitioners as well, MAID assessors and providers were just for the presence of psychiatrists in the room, and how badly I felt that they're so hungry for our input where have we been? And so all of the MAID assessors and providers who were there were incredibly grateful to have that time to talk about challenging cases with us. So that's my second pearl.
Well, I think very much so, and I think involvement with MAID doesn't involve becoming a MAID provider. I think involvement with any of those end-of-life processes is intense learning experience for all of us. So even although some of you will not think MAID is right itself, I think it's really important to be involved in the processes of talking to people about why they want to die, what are their choices, what are their the goals in terms of their end of life and so on, and why they reach that. So I think we can all enrich ourselves with some involvement in that. I think psychiatrists have a lot to add, even not by formal assessors, but by adding consultation, as Mona was saying, and being part of maybe guiding some of the processes, and I think in residency learning about the complexities that people feel towards the end of a life, or when things aren't working, when they're making a decision. And I do think MAID compared to suicide is to some extent risk harm reduction, because I was giving a talk to the coroners, and I think I just briefly mentioned earlier the coroners, and they talked to, a number of them sort of surrounded me afterwards and said how awful it is for them to find somebody who ended their lives by suicide. Sometimes they find them hanging there for 3 months in their own home in total isolation and in really deteriorated state, and how traumatized they feel by this. And is there not a better choice for people to start talking about their wishes? Oftentimes talking about the idea that you're thinking about dying itself decreases their risk. So lots of people who have talked to us about medical assistance and dying, the minute they're approved, they say, now that I know I can die peacefully, I can live again. And that idea that you have some sort of a choice often decreases that distress you feel, and I think might very well result in decreasing those isolated, desperate deaths people do on their own. And it's awful thinking about somebody being so desperate they hang themselves in the basement. Or one of my colleagues was describing a neighbor, blowing his brains out in the garage. The whole family comes, the kids were there, the wife was there, like this kind of thing. And so at least when you apply for a MAID, you have to talk to someone. So they talked to at least 3 of us. They talked to a MAID nurse to start with, 2 of us assessors, and by the end of that, they've done a lot of talking through about why and what's happening with them, and just that having someone listen to them is so good. And many times they haven't talked to anybody, and they just somehow they're disconnected, and it can be such an intensive positive experience. So as I said before, that almost none of my track 2s have ended their lives with MAID, because they got a chance to talk and really explore other options. And so I think it's a really positive experience. And I know most of the residents that work with me have learned a lot, and I've learned a lot over the years I've been doing this, since 2016. So I just invite all of you to be involved in some way, whatever feels right for you, because it's a process that's not going to go away. Maybe we won't get MAID for sole mental disorders, but this process is not going away, because people want control over their death. I think we all do. And we don't want MAID by, we talked a lot just now about voluntary cessation of eating and drinking, VSED, right? So VSED is a terrible way to go. I mean, my maternal grandmother, that's all there was for her, and she was 96 or something, and that's a lengthy death. 3 weeks she took to die. That was long before MAID, and we can do better. Anyway, so thank you, everyone. Thank you, David. You did a great deal of job. I'll just have to thank you before, unless somebody else wants to speak.
I was just going to say that it seems somewhat presumptuous for me to say this, but I will anyway. One of the things that I think I've seen in the development of MAID was when it was first developed in about 2016, there was a whole lot of uncertainty. There was a whole lot of people trying to find their way through. What does this really mean? What is a reasonably foreseeable death? How do you try to determine that? And there were differences. Some of those differences, I think, over time have been diminished by having groups that are involved in MAID provision talking about it and saying, well, these are the ways that we might want to think about it. And I mentioned earlier in my discussion the whole question about how many comorbidities and what degree of certainty do you have to have before you have a reasonably foreseeable death. And I think that the ability to talk among professionals and have candid discussions does help to narrow the variations. I don't know that you'll ever get variations to zero, but you can help to narrow the variations, and you can then, I think, feel somewhat more comfortable. So if you perceive yourself as being out on a limb and you're all by yourself and you are stuck on an ice floe and you suddenly got to decide that whether somebody gets made or not, it's going to be extremely difficult. It's going to be an experience that's really tense. But if you have the ability to communicate with colleagues and say, well, you know, this is what my patient is presenting with, and this is what kinds of treatments they've tried, and this is the diagnoses that I have given to my patient. And here's why my patient says that he or she would rather die than continue living. The opportunity to have the support of your colleagues, and at the very least to say, well, yeah, you know, that's a reasonable thing. It's one of the things that I found in practicing law over many years is to throw out ideas to the people I work with and hopefully get feedback to say, well, you're not completely crazy. And I think that that kind of support can help with your comfort in making those decisions and also in the quality of your decisions. So if you can get involved in any way, and you can have that as part of 2 psychiatrists, 5 psychiatrists, whatever it might be, I think it's going to really help to, if this ever occurs, have a much better system for patients and a much better level of comfort for the people who are then left with the life and the death decision. Where are we going to put chemicals in this person's bloodstream, or aren't we? Thank you.
Any parting words, Laurie, or we can move on for the interest of time as well? But.
My parting word would be just to look at our website on the internet. We were just notified this week that some of our documents don't load on if you're looking on a phone on the internet, and also on the internet on a computer. So we have flagged that to Digital Health for the SHA, and they're looking at it. So, but go to our website.
Add one last thing, not a pearl.
You have 1 minute, Dr. Gupta.
Okay, thank you. No, I just wanted to say, I don't think we need to think about these pearls in the case that MIS UMC is allowed in 2027. I think your local data shows that people with psychiatric comorbidity are making requests and accessing MAID now, and I think our assessor provider colleagues need psychiatric input for those cases now.
Yes. Yeah, thank you so much, everyone, for your input and everyone attending. I do want to call upon Dr. Davidson as well, the program director, to say a few parting words as well. Give her a hand of applause.
Thank you, Dr. Trong. So today's event addressed a really important issue, generating thought and discussion that will allow us to move towards better patient care. Psychiatrists have a central role in working with patients and their families as they try to understand the impacts of MAID and navigate through a complex and constantly changing healthcare system, as we heard today. And as psychiatrists, we have a pivotal role in this ongoing discussion about MAID with our profession and Canada's diverse healthcare landscape. Our participation in events like these is very important for deepening our understanding of the different aspects of MAID and other current and emerging issues. I would like to extend my heartfelt thanks to all of you for coming for Academic Day 2024, to those of you in the room, and those of you virtually watching, and to our esteemed speakers, Dr. Thorpe, Dr. Gupta, Laurie, and Brian. I just wanted to thank you deeply. We're deeply grateful for the engaging presentations and the valuable insights that you shared with us. And I also would like to thank Dr. David Chong and the organizing committee for all of the hard work that they put into making this event today a success. It was really great to see the excellent turnout and get to be in the room with all of you guys here today. And I just wanted to say thank you for coming, and I really hope you have a wonderful weekend. And so thank you guys very much for today.
That concludes Academic Day 2024. Thank you for coming.